over the past few years. Really appreciate you all coming to this program virtually, joining us from many parts of the country and even the world. And today's learning objectives are going to be to discuss the outcomes of artificial intelligence, including machine learning, deep learning algorithms, and disease progression and outcomes analysis. We'll describe the potential of AI to tailor therapies based upon distinct diseases characteristics. We'll identify how AI screening and diagnosis can improve practice efficiencies and patient outcomes, and we'll explain the current limitations of AI and the challenges associated with its use. We'll also have case examples and real-world solutions, and this is a live webinar, so join us today with your questions, and we'd be happy to answer them during the program. We have separate sections in the program, which we're actually going to be pausing with our panelists. You can ask them really in-depth questions about their presentation. This activity is supported by an independent medical education grant from Genentech and Regeneron. I'm pleased to have my program faculty join me today. These are co-directors for the program, Dr. Ted Lang from the Byers Eye Institute, Dr. Jennifer Lim from the Illinois Eye and Ear Infirmary at the University of Illinois Chicago, and myself, Dr. Rishi Singh from the Cole Eye Institute in Cleveland Clinic, Martin, and Stuart, Florida. We also are joined by an amazing panel of participants today, both from research, industry, representing many different people, including abstract presenters. We had a lot of abstract presenters send their programs in for consideration. It was a hard selection, but we have a few people that we were able to choose. I want to appreciate all of the panelists for presenting today for this program. Over 26 participants on the panel today for this program, with over 5 hours of artificial intelligence content. Here are abstract presenters for the program today. I want to again thank them for their participation. Wasn't an easy selection process, but you made the cuts. A lot of abstracts are presented, and kudos to you to making it to this abstract forum. Again, I want to thank our sponsors for today's program, Regeneron, Genentech, and Apellis. Again, without their support, this program would not be possible year after year. And again, we are really appreciative of all of the support that they've provided us. So I'm going to start off the first section of today's program. Again, for Q&A, use the Q&A box below and to answer the questions. We'd be happy to answer them during the panels. And we're going to get started with our first section of today, which is on the foundations of understanding of AI in ophthalmology. And I'm going to turn over to our first presenter, who is Nadia Waheed, who's going to talk about AI in clinical trial design. Nadia?
Good morning. Thank you so much, Rishi, for the invite today, and truly honored to be here. So I'm going to talk about AI in clinical trial design. Here are my disclosures. I'm just none of which are relevant to the content of this presentation. So as all of you are familiar, the growing advent of AI has sparked interest globally across all fields of medicine and healthcare. And we're somewhat unique in ophthalmology because we've dealt for really many years with large data sets, clinical registries, as well as very rich imaging databases that are longitudinal. And these have often paralleled or even preceded advancements in AI, and therefore give us the unique ability to apply AI in our, in our clinical practices as well as in clinical trials, which is really what I'm going to be talking about today. It's also really interesting because, one of the big pieces within ophthalmology is just the fact that within these imaging data sets, many of those are collated, and we're able to see the vasculature in a non-invasive way that you're not able to see in almost any other part of the body, as well as we're able to see neural tissue non-invasively, which you're not pretty much able to see without advanced imaging in other parts of the body. So these are routinely done in our clinical care. Let's pivot a little bit to clinical trials, and why do clinical trials need transformation? So randomized controlled trials are the gold standard of providing level 1 evidence to us, but they face significant challenges, and these difficulties include slow and costly patient identification and recruitment, the fact that traditional trial designs may struggle with inherent variability in disease progression and treatment response, particularly in the complex conditions that we deal with, such as macular degeneration or diabetic retinopathy, and that conventional outcome measures may not fully capture subtle treatment benefits. Now, it's widely understood that in phase 3 clinical trials, when we look at our recruitment rates, it takes 5 to 7 patients screen to randomize one patient into a clinical trial, and the per patient cost is around $25,000 on average, which is astronomical, and that means that these trials are incredibly costly, start to finish. Now, AI-enabled drug development can reduce time. So it reduces time from bench to bedside, but it does more than just reduce time. It outside of just the bench to bedside advantage, it enables us to have rapid and safe clinical trials. It enables us to be more precise with the medications that we're testing. It enables us to test next generation compounds. It reduces the number of patients that you need to enroll in a clinical trial because there's less variability. And all of that translates into less cost. It enables mechanisms that don't work to fail early, and it enables mechanisms to work to be tested in a more cost-efficient and time-efficient manner, potentially. So here in this next slide, so AI can increase efficiency in clinical trials through various different mechanisms, and the ones that I'm specifically going to be talking about today are around optimizing trial design and maximizing and optimizing patient recruitment. So let's talk a little bit about optimizing study design, and let's talk about the trial populations that we use in our clinical trials. Machine learning and deep learning can really help in reducing population heterogeneity. And what that does is it means that your confidence intervals are smaller, you can conduct smaller, more efficient trials. It helps with prognostic enrichment, so you can choose patients who are more likely to have a measurable clinical trial endpoint. And it also may help with predictive enrichment in certain situations where our algorithms are advanced enough to be able to do that. It may help us identify patient populations that are more capable of responding to a particular treatment. All of that means that this precision medicine approach allows for better outcomes and improved study planning at lower costs and lower timelines. And indeed, studies that have looked at this have shown that you can reduce your time by several years, 2 to 3 years, to drug from bench to bedside. So let's look at a simple example of something that we've done at reading centers all along. We look at AI in the classification of GA, right? So you're looking at these incredibly rich images, and AI can help in confirming GA presence, in quantifying lesion size, and in telling you whether these lesions are foveal or extrafoveal, and whether they're multifocal and unifocal. It can really help you map specific trial criteria by trolling through your imaging databases that we already have in patients that we follow up in clinic over time. So this was one of the studies that came out of Moorfields, talking about how it can help with identification of diabetic retinopathy and accelerate identification. It can also help grade the level of diabetic retinopathy and look for DME or not, and help really precisely identify patients who may be candidates for your clinical trials. And in this study, where they looked at patient identification and cohort composition, one of the things you can do with AI is you can look at a clinical trial site. You can pre-screen all the patients in clinical trial sites to find out how many patients they have that may be eligible for your particular clinical trial. Not only can that help with site selection, but it can estimate the time that it takes to do manual chart review. In this study, for example, where they looked at Moorfields database, the estimated reduction was of an 8-week manual chart review, which 2 months is quite significant when you're looking at clinical trials. So this is what this study did. It looked at an EHR-based chart review, a purely AI-based imaging review, and then it looked at combining EHR chart reviews with AI-based imaging reviews. And what they found was that the AI-based imaging review actually gave you the highest number of patients eligible. So it was the most sensitive method of identifying patients for this clinical trial. If you wanted to look at something that was a little bit more specific, you could do an EHR and AI combination, and that was the most specific. It gave you smaller numbers of patients, but the highest percentage of patients that were eligible. Both AI alone as well as EHR search enhanced by AI did much better than an EHR search alone. So not only does it reduce the timelines, but also improves the quality of the patient population that you're then able to get. So we've talked a little bit about matching a trial to patients, but what about patient to trial matching? What about if a patient comes in, can you look at a list of clinical trials that these patients may be eligible for? And there's actually quite a bit of work that's being done in this. Trial GPT, developed by the NIH, for example, helps streamline recruitment. And the goal is to lower screen fail rates, as well as decrease recruitment period, as well as give our patients more choices of available emerging therapeutics that they may be able to avail of. You can also use AI for patient monitoring during the clinical trial and to identify patients who've reached specific measurable endpoints. But the important thing to also remember is that the AI that we use is only about as good as the data on which it's trained, right? And so we have numerous challenges around validity and generalizability of the different AI algorithms. And there's a real push towards standardization of these algorithms to make sure that they hit certain quality benchmarks as well as certain ethical benchmarks. I think a critical thing to remember is that AI models can be biased if they're trained on limited or imbalanced data sets, and therefore diversity is your friend here because large diverse data sets help improve accuracy of your AI and help improve generalizability of your AI algorithms. And of course, always to consider when you're using AI in clinical research is to think about the ethical considerations around the use of AI and to conform to this effort around setting ethical guidelines, such as the CONCERT AI guidelines around the use of AI in clinical trials. So the key take-home message is that AI holds immense potential to make clinical trials more efficient, less costly, and more insightful. But increased adherence to guidelines is crucial for reproducibility and accelerating the translation of AI into clinical research and practice. I'm going to end over here by thanking two of my colleagues that were instrumental in this presentation, as well as my fellow Usman. Thank you so much for your attention.
Thank you, Nadia. That's a great presentation, really helpful because obviously our field is advancing and this detection analysis may be pre-screening of patients. So really wonderful. We're going to answer some questions for the audience. And again, for those watching, please feel free to ask questions in the chat box, and we're going to get to them at the end of this section. I'm going to turn it over to Dr. Anat Lowenstein. She's going to talk about pivotal studies toward the effectiveness of AI-based analysis and home-based OCT and its clinical implications. Dr. Lowenstein?
Thank you very much, Rishi. I think the talk of Nadia was exactly a great platform to my talk. And I first of all would like to thank you, Rishi, Jenny, and Theodore for the invitation to join this very exciting and prestigious group of speakers. Takes a minute for the slides. These are my financial disclosures, the relevant of which is being a consultant to Nutal Vision, which developed the discussed technology. The reason I'm saying that the talk of Nadia was a great platform is that I will mainly focus on the fact that we do have AI first ever OCT, which was cleared by the FDA, and I'm going to discuss the pivotal trial that made us achieve this very significant milestone. And part of it is exactly the validity of the AI. So just to remind everyone, the home OCT allows patients to self-acquire OCT images at the comfort of their homes. It provides insight into disease dynamics over time. It's powered by AI, that's why it's relevant to this session. And as I said, it's the first ever home OCT and first ever AI on OCT to be cleared by the FDA. So if we see these two patients, they look very similar. They have two visits. In both visits, for both patients, they had subretinal fluid. However, there is a big difference between the patients. The first patient didn't have fluid in between, whereas the second had fluid all along. And of course, this is data that we'll get from the home OCT that will help us really understand what happens in between patients. The first patient, for example, would have benefited from maybe an earlier retreatment, whereas the second patient would have needed maybe a different treatment all along or an earlier switch because he had fluid all along. Of course, this so much data achieved by daily OCTs from so many OCTs from so many patients cannot actually be managed without AI. the physician would not be able to oversee and to get conclusions without the use of AI. So the AI-powered algorithm automatically quantifies the presence of subretinal and intra and total retinal fluid, provides this map, and then also this trajectory that converts the 3D volume scans to 1D fluid volume trajectory, which makes the physician very much possible to use it. And I would like to now, in view of the topic of this session, to walk you through the pivotal trials which led to the FDA authorization of this AI-based home OCT. So we had a qualitative visualization study and a quantitative AI study, and each of them looked at different aspects of the technology. The visualization study looked at the question if the home OCT can be used by neovascular AMD patients, and is visualization of key biomarkers the same between in-office and home OCT. The quantitative AI second study actually looked at the question if the estimation of the key neovascular AMD biomarkers is repeatable and similar for expert graders and the AI. We needed to term some kind of new definitions, looking at hyperreflective spaces, intraretinal, subretinal, and total hyperreflective spaces, and at volume units, because we know that not all hyperreflective spaces are actually units, hence the more accurate definition. So for the visualization study, it was a prospective longitudinal study. Sorry, I need to go back. It was a prospective longitudinal study which looked at the fact if the reading center triggered interim study visit decided if the intraretinal or subretinal hyperreflective spaces were noted. The home OCT was shipped to the patient's home. They needed to complete the whole setup and calibration. Their task was to perform daily home OCTs. And then in the office, they also had visual acuity and office OCT, and the reading center graded the home OCT and then the in-office OCT scans for hyperreflective spaces. So when we look at the outcome measures, you can see that for the home OCT, both for the positive predictive agreement and negative predicted agreement, was 95%, which brings to a very high agreement for this particular trial. When you look at the percentage of patients who were able to activate, that was 96%, which is a lot. And the patients were very adherent with 5.9 scans per week. And the time per scan was very short, of 48 seconds only. So the visualization study did meet the primary endpoint, showing this good agreement. For the AI study, this study looked at the repeatability of the AI output, how close are the results of quantification on the same eye on repeated measurements, and on the agreement between the AI and human expert graders. How does the variability between AI and graders compare to the variability between graders? So the patient acquired multiple scans on 2 home OCT devices. All scans are processed with AI-based algorithm for subretinal or intraretinal hyperreflective spaces for segmentation and volume estimation. 10% of the scans of 1 OCT scans that were annotated by expert graders. Then in the office, the patient acquired 1 scan on a single in-office OCT. And the in-office OCT scan was annotated by 3 expert graders. Patients included were same patients as in the previous studies, patients that are recruited to all our AMD trials. The outcome measures the repeatability, the similarity of quantitative estimates for the same eye with multiple scans or grading episodes. And when you look at the volume, which was high enough, the repeatability was very good. for the agreement, namely the similarity in segmentation by AI and graders, which was measured by a dye similarity score. This is the explanation of the dye similarity score. And you can see, again, that the agreement was high. I'll skip this slide for the sake of time. So the results for repeatability were 11.1% for the home OCT and 16% for the in-office OCT. So the variability of AI-based segmentation was smaller than the variability among graders. So this is a very important parameter, very good outcome measure. It seems that the AI algorithm combined with the home OCT shows good precision for total retinal hyperreflective spaces estimation. And this allows for identification of clinically meaningful trends in total retinal hyperreflective spaces. And for the agreement, you see that there is both precision and agreement for total retinal hyperreflective spaces estimation. So the patients demonstrated a high success rate adherence to self-imaging. They were able to operate the device, and the comparison of the home OCT and the in-office OCT for visualization of total retinal hyperreflective spaces met the pre-specified agreement endpoints, and the comparison of AI-based estimation of these spaces with human graders showed good both precision and agreement. So it seems that this system meets the bar for efficacy and safety that allowed for the de novo marketing authorization from the FDA. Thank you.
Right. Thank you very much, Dr. Lowenstein. We're going to get to questions for that. That's a fantastic presentation. Looking forward to home OCT now that it's FDA approved. So I'm going to turn it over to Manaj Alam. Dr. Alam is going to speak about the foundational federated learning for ophthalmic diagnostics. Dr. Alam.
Thank you, Dr. Singh. Really nice to be here. So today, I'm going to present our group's work on foundational federated learning for ophthalmic diagnostics. So we all know that advanced AI methodologies have already demonstrated huge potential in this field of ophthalmic diagnostics. AI can enhance diagnostic accuracy, increase accessibility to this kind of generalized models. It can help monitor disease progression, also scale up, and there's a cost effectiveness in that has been already demonstrated. And in recent years, foundational models have addressed the need for multitask learning in AI-based diagnostic tools. We all know about RedFound, and it has profoundly impacted this field where previously we had to train N models for N type of tasks from N type of institutions or retina clinics, right? And foundation models are this kind of new generation of AI models that are trained on large, diverse data sets. And it can be adapted to different downstream tasks. So basically, this disrupts the task-specific paradigm of current AI models. And then it also addresses the multitask learning problem, where in a generic hospital or retina clinic, a patient doesn't come and we say diabetic retinopathy or PDR. We say, okay, is this patient diseased or not diseased? Then we found out, okay, what kind of disease they have, what is the staging, and then we go from there. So it's a more holistic approach. So kind of foundational models mimics that workflow. Generally, foundational model provide this by leveraging multimodal learning and some sort of pre-training like self-supervised learning, mask image modeling, etc. So obviously, when we're talking about this huge amount of data, there's always an issue of, in an ideal world, everyone would just upload their data in a central repository, and we would be able to we were able to train large models, multimodal models on that. But that's obviously not possible because there's lack of large amount of these well-curated data sets. And then there's limitation to build and host these large central repositories. And of course, there's like compliance issues, sharing concerns, regulatory issues, because these are all patient data. So there is a clear clinical need for a robust AI model training framework that can leverage data from multiple institutions and still does not compromise data sharing concerns. So in this case, in the right side, if you can see, the global learning is facilitated by a federated learning framework. Federated learning provides data privacy, diverse data access, and this kind of collaborative training towards large foundational models. So basically, federated learning is a machine learning technique where multiple decentralized nodes, in this case, different retina clinics or hospitals, can collaboratively train a model while keeping all the training data local. So I can just quickly show how federated learning works. Is basically you have multiple hospitals. They have their own local data and own local model. The way a deep learning model is trained is that they get updated in each iteration. In this case, the updates are shared to a central server or a global server, and that is aggregated based on different criteria, strategies, and data weights. And then those weights are sent back to the local nodes and they get updated. So without accessing the data, each node or each hospital is getting a model that has been aggregated or updated based on all the data sets, but without accessing this data. So that's the kind of the beauty of federated learning training framework. We have been doing this for a while, and there are a couple of gaps that we basically address in our we're trying to address in the federated learning research beyond showing the feasibility of federated learning, which has already been demonstrated. One of them is data heterogeneity. For example, the data distribution can differ and different aggregation schemes are needed that preserve local patterns, but still get global, like very generalized performance. Also, label scarcity and self-supervised learning helps because labeling is expensive and this kind of pre-training can leverage this unlabeled data. And then there's an issue of external generalization versus personalization, because every institute that are part of the consortium of this federated learning, they might want a very good generalized model, but also can want a very good local model. So how do you address that trade-off between getting a very good, precise local model versus getting a generalized overall global model that performs equally on all the data sets? So I'm going to quickly just present one of our recent papers that was published in Nature Communication Engineering, where we demonstrated distributed training for foundational models for multi-class classification problem, where we mostly, we had access to 7 data sets. 6 of them was public, openly available data sets, and 1 was data set from UIC. So we took multiple approaches where we trained all of them, or we trained on public data set, tested on private UIC data set, and all those things. And then we also did a pre-training using self-supervised learning and mask image modeling to enhance the representation learning capability of the deep learning model. So these are the split of the data set. As you can see, there are multiple type of disease. You have normal drusen, DME, CNV, and then we have mild, moderate DR. So it's a multi-stage, multi-disease problem. We compared our federated learning approach with local learning pipeline, where we trained local models on all the local data sets. And then we also did a centralized learning pipeline where we uploaded all the data in a central repository and so this is the best case scenario, what kind of performance we'd get. And the mask image modeling is basically an unsupervised methodology where you do some sort of this kind of masking of the image and ask your model to predict what's missing. By doing that, it enhances the capability of the model to improve the model performance, understand the nuances of the OCT imaging pathologies. Something like this, where you have input, you mask it, the model tries to predict it. By doing this, the model gets better trained. This is our federated learning pipeline. I already described this a little bit. And we also do some sort of domain adaptation because each model, each data set has some other variability like contrast, the photography, devices. So we use a domain adaptation methodology where you can see each of them have different contrasts and try to converge them to a kind of similar type of contrast and background that helps the model converge faster and get better performance. Result summary, basically, we saw that federated learning outperforms all the local models. When we use domain adaptive federated learning and we use the mask image modeling on top of that, it performed even better, a little bit better than the centralized model. So without getting access to the model or to all the data, the federated learning framework was able to outperform a centralized DL model. So I'm going to skip this. This is basically another method of showing the pre-training using diffusion modeling. Currently, we are focusing on this work where we're trying to do a data-aware aggregation that preserve local performance when needed, or try to get the optimum global performance on the model. So we do that by federated learning eigen feature-based aggregation, where the model gives consideration to different institutions that have similar type of data. So in summary, there's a lag. So take-home message is basically we have demonstrated that distribution approaches like federated learning are beneficial for training this kind of large-scale multifunctional foundation models. Many scientific and fundamental limitations still exist that needs to be addressed on the technical side. And then model validation and pilot clinical deployment are necessary for real-world feedback. So these last two are on the thrust needed in the technical side and in the clinical side, where we work together with clinicians. And that's all for me. Thank you. And I'd like to thank our collaborators, Dr. Lang, Dr. Lim, and Atali and Sally from Wake Forest, and our support from NIH. Thank you.
Thank you, Dr. Alam. So great presentation. I'm sure we'll have some questions for you in the chat when we get to the next section. So please stay on for the panel. I'm going to turn over to Dr. Peter Campbell. He's going to talk about super resolution for AI, OCT image quality, use GANs to enhance undersampled NFOS OCT images.
Thanks, Rishi. Great to be here. I'm going to talk about a slightly different topic today from our experience looking at handheld ultra-wide field OCT. These are my disclosures. I want to acknowledge I'm part of a really large team, and this work was presented by my colleague, Aaron Coyner, who's really the brains behind the methodology here. So going back to the fundamentals for OCT, we remember that we use fast lasers to scan an A scan, 1 point, a B scan, 1 line, and then a C scan, a bunch of lines in a row to get a volume, and that can be viewed cross-sectionally or en face. In the typical OCT application of the macula and typical laser speed to even spectral domain, we don't really have a problem getting enough samples to have decent resolution. But there is a tension. As you want higher resolution, more samples per degree, you want wider field of view, it takes more time. So you can, in theory, do as many samples as you want across as wide of an angle as you can visualize optically, but it takes longer. And so there's this inherent trade-off. And as we think through this, different applications will require different trade-offs. So when we're imaging babies, a lot of my interest has been looking at retinopathy prematurity. We want really high speed and wide field of view. So this is a research prototype. We've gone as fast as 800 kilohertz using swept speed. And this can do a 1 second scan for OCT and a 1.9 second scan for OCTA. But there's a trade-off. It requires a faster laser, which is more money. And there's other trade-offs as well. The faster laser you go, you can lose axial imaging range. And so there's all these trade-offs. Faster is not always better for what you're trying to do. But that laser allowed us to get images like this, where we can see the entire area of pathology. But there's a trade-off, because as you zoom in to try and look at the typical, the macular scan, for example, you can see that we're relatively undersampled compared to what we would normally expect from a macular OCT scan that we look at in adults, for example. And it turns out this is a fairly common problem, and we can learn from our radiology colleagues. You imagine trying to image children in a CT scan or MRI scan, there's issues both with them moving, and there's also issues with radiation exposure. And so I'll just give you a quick example. This is a paper from looking at PET CT in children with cancer. And this is one of those issues where the longer the scan is, they get better quality, but you get more motion and you get more radiation exposure. And so this is a PET CT scan where they typically have the kid in there for 600 seconds. And they experimented using AI to say, hey, can we upsample shorter scans? And so they went as low as 6 seconds. And I'll show you what it looks like. And I'll give you the summary here. So basically, in a 6-second scan, you get a lot more noise compared to the 600-second scan on the right. But if you train an AI to compare those two with enough data, you can get a 6-second scan upsampled with AI, called super resolution, to give you better quality. And again, you can see the obvious benefits here: less motion, et cetera, and better quality with less time and less radiation exposure. And it turns out, again, we can learn a lot from our radiology colleagues. There are several technologies like this that are already in clinical practice. This is an MRI scan, and this company, was able to upsample and reduce MRI time, which obviously has many advantages both for the patient and for the company. And so the question we asked is, could we do the same thing for ultra-wide field OCT? Again, this is not simply about cost. There's trade-offs as you go to faster lasers, which you may want to consider depending on your application. And so on the right is a 800 kilohertz laser at 0.8 second acquisition time. On the left is a downsampled equivalent to a 400 kilohertz laser at 0.1 second, or you can imagine a 100 kilohertz laser at 0.4 seconds, same idea, same sampling rate. And you can see the image on the left has much lower resolution, may or may not be good enough for clinical use. So what Dr. Koyner did is took our existing data set from OHSU, downsampled a bunch of the images from 800 kilohertz down to a much lower resolution, used a best buddy GAN architecture, and then we evaluated it both qualitatively and quantitatively on an unseen data set. So I'll give you a couple examples here. Here's one example, again, 800 kilohertz, 0.8 seconds. That's our standard scanning speed. Downsampled, you see, again, much grainier image. May or may not be good enough. You may accept that trade-off. But AI was able to sort of bring it much, much closer to the original acquisition resolution. And that's able to work in basically real time, so 0.1 seconds. So you can actually visualize this in real time, even with a 0.1 second scan. And again, just the before and after. Again, the image on the left is the super resolution image. I'll give you one more example showing it's not always great. Here's an image, the original. Here's the downsampled image, and here is the super resolution image. And I think I have that larger side to side. And again, you can see the image on the left. You can clearly see there's some almost like a smudge on the lens. You can tell there's something off about it. And again, these are GANs, so like we're all familiar with these architectures can hallucinate. They fill in, they make up data, and that's one of the risks to them. I'll skip over this. Basically, we looked at two different similarity metrics, and we looked qualitatively at the images for clinical diagnosis purposes. And so, in summary, super resolution appears to be effective at increasing apparent resolution and gradability of ultra-wide field on-FOSS OCT images. It enables faster imaging and or higher resolution scanning. And again, a faster is not always better, so there may be reasons you want to use a slower laser as we do a wider and wider field OCT. These models can hallucinate, so we need rigorous clinical validation to ensure safe and effective implementation. And one obvious application for not just pediatric OCT, but as we talk about wider and wider field OCTA, if any of you have experience using some of the newer devices coming out with wide field OCTA, the acquisition time can be quite long because OCTA requires even more samples per area. You have to essentially repeat multiple times. And so you do get more motion, you get more acquisition time. And so I think that's maybe the biggest application for this type of technology would be to denoise those images and allow wider field OCTA in less time. Thanks so much.
Great presentation. So I'm going to turn it over to Dr. Vagheffi. I'm sorry if I said that incorrectly. to focus on the role of AI in early detection and management of cardiovascular risk and chronic kidney disease.
Well, thanks, and thank you for having me. And that was a great pronunciation of my surname. So a bit of a, again, different presentation as our previous presenter mentioned. So I'm the founder, CEO of Toku, and at Toku, we believe that every eye exam may save a life, and that's obviously powered by AI. So we established Toku back in 2020. So it's about 4 or 5 years that we've been doing this. We are focused on identifying silent diseases through retinal images and focusing mainly on cardiovascular disease and chronic kidney disease in this point in time. These diseases, again, as we know, most people that have cardiovascular disease or chronic kidney disease are not aware of it. And all of these changes to your macrovasculature shows up in the back of the eye, and that can be captured in optometry, ophthalmology, or primary care by retinal imaging. Point being that we are just enabling the doctors to do pre-screening and screening for the diseases that affect most of the human beings. So we have been essentially targeting optometry at this point in time. The main reason for that is majority of people have an eye exam once a year because they need new glasses or contact lenses. 120 million Americans have an eye exam every day. That's just a staggering number. And we believe that by essentially providing our technology in every shopping mall, high street, we capture a lot of disease. When we're talking about a medical product, obviously we are talking about gold standard. So what is the gold standard for identifying these sort of diseases? For cardiovascular disease, we are matching American Heart Association gold standard of having a high risk of cardiovascular disease. And at this point in time, we are more than 90% accurate sensitivity and specificity using just a retinal photograph. Chronic kidney disease, we are matching the gold standard developed by National Kidney Foundation. And again, as of today, we are more than 84% accurate in predicting chronic kidney disease using only retinal images. We are a big fan of doing good science. So 14 publications, I think 15 publications, actually, one just came out. 4 patents as issued and granted as of today, and 2 FDA breakthrough designation. So with all of that, what we are trying to do is to make sure that we have these products available to the public as quickly as possible. Our first product, which is called BioAge, is about biological aging, and we are trying to match the American Heart Association cardiovascular aging language and standard. It is approved in the European market, in Britain, and here in the United States, and being commercialized. Our cardiovascular screening product, Claire, is approved in the European market and the UK. It is going through its FDA process as of today, and we believe that it's going to become available commercially here in the US early next year. And our kidney product should become available sort of later next year. And beyond that, we have a pipeline of these products that will hit the market. Essentially, every time we enable more and more disease identification and screening through retinal imaging. I have to mention that both BioAge and Claire right now are being sold in the European market and in the UK. One of the things that we learned doing what we do is that, again, it's all good and well when you have an AI that does something amazing. However, it has to fit in the workflow of the clinic that you're trying to deliver it. So having a product that doesn't break the existing workflow matters as much as sensitivity and specificity of the So right now, we are sort of integrating with existing hardware and software in optometry and ophthalmology. Point being that we don't want to break the flow of an eye exam. The patient comes in, they're receiving a retinal imaging as part of the routine eye exam. Within 30 seconds, we let the doctor know that there's another report around the biological age or cardiovascular risk of that patient, depending on the jurisdiction. And that is then added to their EMR. So the doctor then has access to our reports along with everything else that that patient has done. It makes that easy for the doctor and then also for the patient. And if there's referral to be made, that's also part of the EMR. So it's all about integration. Also want to talk about a bit of a marketing data, although the presentations up until this point were not about financials, but I think those are, again, very, very important. You can have the best AI in the world, you can have the best workflow in the world, but if it's not financially sustainable, unfortunately, that is not going to change the world. So as of today, we've shown that the clinics and these clinics have been in California and Texas, the clinics that have provided our technology as part of the routine eye exam, they've had 31% increase in their ancillary sales. Those are the medical side of the clinic. 20% more in the retinal screening, and patient satisfaction and clinician satisfaction has gone up. Again, all of these are essential for the utilization of AI, and I cannot emphasize the fact that you can have the best AI in the world, but if it's not utilized, I doubt it will change the future as we think it would. So with all of that in mind, at this point in time, we are engaged in retail optometry. I have to say, as of today, we are also offering our services in ophthalmology and primary care, but mostly in optometry. We are soon getting involved with more pharma companies that are interested in, as our first speaker mentioned, in clinical trials and how do we recruit people for our clinical trials. And, and again, optometry, you're screening 120 million people. I don't know a better place to recruit for patients for a safe clinical trial. We're also seeing a lot of innovation in the tech industry when it comes to the eyes. Meta, Google, OpenAI, they have all come up with their own hardware about just sort of getting the AI literally on the face of people in front of their eyes. I do see a future that all of these gadgets that are now wearables and trying to bring AI to your vision will become a part of your diagnostics. And the glasses that you will be wearing maybe in 5 years' time will become a diagnostic tool as we move forward and adopting these technologies now in our day-to-day job. So with that, I just want to leave you with this message. I do believe that Toku is becoming the front door for healthcare. That is essentially converting every eye exam to a comprehensive health screening, and we're just getting started. Thank you for the opportunity.
Thank you for that presentation. That's wonderful. And I'd love to see, again, questions coming up in the chat, which we're going to get to at the panel discussion. I'm going to turn over to the next presenter. Advance the slide here. Okay, and the next presenter is Dr. Jo Chen Kam. She's going to speak on the implementation and delivery of AI in ophthalmic at scale and in a diverse setting. Dr. Kam?
Hi, thank you for the invitation. Super excited to share some thoughts. All the previous talks were inspiring. I'm going to sort of pick up where San left off and dive a little deeper. So I have focused as part of a founder and CEO of Prevent in implementing AI and deliver it in a variety of settings. You can't do everything everywhere all at once, but you can try. I want to do my disclosures. I'm not going to dive deep into Prevent here. We're a pediatric retina screening company, but I've been advising and helping implement in a number of pediatric and adult settings, including other platforms such as genomics. Deeply grateful for the many people that have helped and the many places that have supported us here on the slide. And before we start, I have to ask this question. Is today's AI good enough? Yes and no. I mean, I did ask an AI to make a retina image, and I got these very pretty but useless images. So there is a question to be answered still. And many of you may know this, but a very good summary of the state of AI in terms of single models is this one, where you had 2.9 million taxi rides in Manhattan. Looks very good. As soon as you disrupt the system, you get some very interesting things where taxis jump through time and space in unpredictable ways. So I find this a very helpful visualization of where we're at today in terms of problem solving. I'll go pretty fast. I mean, We come from a world of deep learning, one model per task. You may have seen this from other presenters. Then there's the foundation model. I think that's the prevalent in ophthalmology today, where we have one model for many tasks, as well as the multimodal foundation model, if I can make this slide move, which has many inputs and many tasks. And then where things are going now is a multi-agent model where you have many foundation models working together. And if you look at the timeline here, it's accelerating. It took us almost 10 years to go to a foundation model. It took us another 2 years to get to the multi-agent model. We'll go faster. If I can, I'm trying to make the slides move. Let's forget about that. We need to build. 2 years ago, we were building things like that are very structured and had sort of the modalities, integrating the data, providing disease apps, and then providing real domain support. And I think that was reflected in Ehsan's talk, where he has managed the disease areas. Bringing much data together is an advantage. This is not my job to explain this here, but here's a slice of OCTs. And you can see that if you look at any given image column, then you can have very different results, but as you integrate over time, over slices. One of the key things that I find very exciting, and that's becoming relevant to implementing it, is a very recent paper here that shows that even simple augmentation of a foundation model, such as including age and gender in the analysis, can tighten up the results. And I'll mention that later and explain how that becomes relevant in deploying it. It is quite striking. The other thing that is emerging today, which is puzzling me and creating a certain amount of excitement, that is, as you look at the retina, you're increasingly looking at many different diseases. I think it's difficult to look at the retina only as an ophthalmic disease area. And the data coming from many, many papers tells us that it's broadly relevant and we should use it. Because despite the limitations, we have opportunities. So when you start building things, you have to start, there's a checklist. The must-haves are pretty obvious, but nonetheless worth mentioning: safe, effective, reliable. It has to be approved. It has to be robust, and it has to be affordable. I'm going to focus not on all of these, but some of these. The robustness is important, and we're getting better at this, and building it, and safety. So safety, multiple aspects of that. I'm going to say that we are at this point able to build safe AI models using HIPAA, high-tech, GDPR, and other standards incorporated into the architecture to actually build safe deployments. And we have done that in multiple locations, multiple disease areas, and multiple continents, actually. And here's a summary. It's not something we need to discuss here, but the standards are out there. Now, the big question in my mind right now is that we need regulatory approval. I'm going to focus on the FDA here. There's been an ongoing effort since 2019. They pay a lot of attention. Much progress has been made. And yet, I will argue that today, because of reasons that are beyond my insight, is that the FDA is focused on implementation over function. Meaning, where do you deploy this? Which device is it on? How does it display things? This is very helpful, but it doesn't apply to all models. And forgive my stupid title of this slide. But as we're moving forward, remember we're moving already from multimodal foundation models into multi-agent foundation teamwork. AI may not be device dependent. It may actually be a technology of its own. I do profoundly believe that how to use it is and should be up to the doctor, because the kind of decisions that are being made about when to treat, how to treat, and in what way is a doctor's decision. What's not on this slide, but it's recently that doctors largely agree. Many people use AI, whether or not it's approved, they use it as a support. And we're going to skip that. There are differences between supervised and autonomous AI. And we do actually have a state-of-the-art, we have 3 approved autonomous AI algorithms with a substantial number of Medicare claims. Liability is sometimes clear, sometimes not. If you're screening for diabetic retinopathy and you find a kidney disease, how do you handle that? Unclear. Is a concern in real world. We've heard so much of foundation models, we know we can skip that. The rules of thumb for building AI is it has to be bigger, it also has to be smaller because of cost. It has to be smarter, meaning it has to move towards the foundation model thing. It has to be actionable. It has to actually deliver something. So this slide is here to say that we have moved from this to much more complicated models. Here I'm going to slow down a tiny bit to just get to the point of my talk. If I can make it move back one more thing. Oh God, it's going forward. Yeah, okay. So 2 or 3 years ago, we had this grand visions of the doctor being in this massive AI-supported space, looking at everything. I don't think that's necessarily where we're going to go. In our implementations, we have basically focused on making it as simple and invisible as possible, where we enable the doctor to provide better patient care. Here is a core slide that I think summarizes a lot. When we build architectures, we have a whole bunch of things going on. We have patient registration, we have multiple cameras, we have databases analysis, and there is a tiny spot for AI. That doesn't mean it doesn't matter, but it's part of a larger ecosystem. And having it modular like this means you can plug in and out as AI evolves. Here are some things that become relevant for us to deploy, which is that much of the actual workflow in AI does not need to have patient information. We can work with data that is de-identified, and that makes a big difference for actually getting it out into the world because it makes people more comfortable using AI. And so I wanted to say that break it into simple pieces. All of it's available in an architecture such as this one, and we can provide it. There's one more slide I want to really emphasize. This kind of flow diagram that tells you what's happening in the world can translate very nicely into a cloud architecture. Here's a Google Cloud example. And it's really, really better than building it at home with all the security, administrative support, and modularity built in, so to speak. And simplicity is key, but that's not what I'm going to touch here. And we've talked about this I am paying attention to time. We do have the capability of providing a lot of information picture by picture in interfaces. We, like many, have run retrospective study, and we achieve things that human graders can't achieve. We know that, and it's not here. How do we use this kind of stuff? I think there are multiple possibilities of deploying it in training, in providing assistance, scaling and prioritization, and cost savings. There are many ways of using AI in terms of making it more efficient. Here we have a whole bunch of recent papers that generally show that AI enhances performance. We've learned that before. I want to point out that the green frames generally show models that are now much more foundation model based and not feature based. Oops. I believe I just moved into someone else's talk. I'm so sorry about that. I'll just leave it at that. I want to draw attention to the scientific data paper, which is actually a first effort to share data for other people to use. I respect that a lot. And in the interest of time, I just want to say that we all like using AI. As a joke here, I'm telling you what ChatGPT suggested. I did edit it. But the take-home message is it's working. If implemented correctly, it should be incorporated in the workflow. It can be compliant, but people have to use it in an intelligent way. And generally, I am opposed to autonomous AI in favor of collaborative AI that enhances the doctor's capability. I'll leave it at that. And I'm asking the FDA, I'm no longer touching it. The same people that have contributed massively. Mm.
All right. Thank you very much, Dr. Kama. Really nice presentation. I'm going to have all our participants get on now, and we have some time for some questions. Really appreciate all the presentations. I think one foundational question, maybe for all of you, since we do have about 5 minutes for our Q&A right now, is on the medical legal side of things. So you guys all presented, very, very interesting applications, sometimes enhancements, but both on the image acquisition portion and on the analysis and output portion, there are probably some medical legal concerns. So I'd just love to hear kind of how maybe you all are approaching this in your own specific way. So maybe start off with Dr. Lowenstein. Yeah, that'd be great.
Yeah, I want to emphasize, and I think it's clear to all of us that the responsibility at the end of the day will be ours. Doesn't matter any legal decisions that will come regarding AI recommendations and decisions. I think the response, and without knowing too much about that, I'm just positive that regardless of the technology and the specific AI used and all the legal implications, we are the ones to be responsible. So if we are using the AI, we need to really acknowledge the fact that at the end of the day, we are the liable ones.
Yeah. How about Dr. Vagafi, with your presentation on the risk of both kidney disease and in patients with cardiac issues, what happens to a patient who doesn't get that information or may not understand it or maybe not even, receive it because it's been something that was delayed in some way? Is there a medical legal concern from the perspective of Toku and what you guys are doing?
Oh, that's a good point. So we make sure that there's always a human in the doesn't matter if you're in ophthalmology, ophthalmology, or primary care. And the results are shared to the patient, with the patient, by the doctor. So, you've got to remember AI can be synchronous. As soon as you're having your results or images, you can have your results. So the doctor quickly shares the results with the patient. You also then follow up with the patient through email contacts and all that. Also, the other thing that I think a lot of people ignore is AI at any step is just one decision and you need follow-ups. In that the patient receives a certain outcome, like for example, you have elevated cardiovascular risk. If you end the conversation there, that's a very poor patient outcome. You need to connect the patient to the next person. Who is that person? Is it a primary care provider? Is it a lab that they go and do other examinations? So, we talk about AI, to be perfectly honest with you, AI is the smallest piece of this puzzle.
Dr. Kum, you had your hand up?
Yeah, it's been said almost. I think that there's a delicate balance, a trade-off, right? The follow-up thing is what I wanted to mention. It's so important because in my conversations with patients, when you tell them something, they want to take action. So we work very hard to connect our system to follow up, but legally it's often very difficult to step into the care provider role. So I think there is a lot of work to be done in that arena to connect AI. And I've also heard questions from doctors. Other people can answer this for me. It's like, am I going to be overloaded with the AI referrals that are going to make my life difficult and possibly boring because they might be oversensitive? Anyway, so those are real life questions I've encountered.
So maybe I could ask a general question. Who is getting informed consent as part of their process? I think Dr. Campbell, you probably do it as part of your screening evaluations for patients with ROP, and hence this data is post hoc analysis. So you have some sort of informed consent with the patients or I guess the parent of the patient in your case.
Yeah, so my talk in particular used a research prototype device, so all those patients are consented. But the nurse in our case, we have a lot of support from the nurses because they see the pictures, the parents see the pictures. It's less stressful than an indirect exam. So we get almost 100% consent.
How about Dr. Waheed? In the screening process, we don't really get informed consent, right? Because we're doing this post hoc. Is there any need for an informed consent or patient interaction before we say, hey, wait a minute, we saw GA in your pictures. Maybe your doctor didn't talk to you about it. Is that a concern for anyone who's doing pre-trial screening and calling those patients in?
Great question, Rishi. And I think this is something that we kind of question. It, I think, depends to a large extent on the setting. So in my setting, for example, where you're in an academic institution and patients sign a consent up front allowing for review of post hoc information, I think as long as it stays just within a review of images, it's very reasonable. But obviously, if you're running a clinical trial and patients have not signed off on consent, this is always a question whether you're able to mine their big data or mine large sets of data to do this. At the end of the day, the AI algorithms are identifying patients for within a federated environment for physicians to be able to contact or not contact and get consents. But this is a great question. I think this is something that we need to sort through as these AI applications get bigger and larger.
Yeah. Okay, great. Awesome. Well, thank you all for your presentations. There's some more chat questions. So if you don't mind, you could look at the chat and the Q&A and answer them yourselves for those who are designated. I really would appreciate it. Thank you all for your presentations. We're going to move on to the next section. Appreciate your participation. And the next section is going to be kicked off with Dr. Let's pull the slides back up here. Excellent. Next section is going to be Dr. Ursula Schmidt-Erfurt. Yep, on the clinical applications of AI for AMD in the evaluation and management. Ursula? I'm not hearing any audio right now. Maybe we can pause and.
Hello?
Yes, I can hear you now, Ursula. Sorry about that.
Fabulous.
Good.
So my name is Ursula Schmidt-Erfurt from the Medical University of Vienna. I'm talking to you about clinical applications of AI, particularly for AMD evaluation and management. These are my disclosures. Next, please. Next, please. So obviously, clinical management is driven by clinically meaningful biomarkers. Retinal fluid is certainly the one biomarker that we are all most familiar with. Next, please. This is because fluid is easily visible on an OCT image, and there are no doubts about whether there is fluid there, yes or no. However, what is most important for fluid as a clinical biomarker and its relevance is the compartment. Is this fluid within the retina, underneath the retina, or underneath the RPE? The other most important feature, obviously, is the quantity. It's the volume, what we use to measure on central retinal thickness in a two-dimensional manner is most realistically measured as a volume if you're using AI to identify it. Next, please. So why is fluid compartment and fluid volume relevant? Because it has a strong impact on central visual acuity. So intraretinal fluid is shown in red, subretinal in yellow, and PED in blue per volume. And you can clearly see that the more intraretinal fluid you have, and this applies to intraretinal fluid much more than to other fluid compartments, the more the visual acuity will decline. Next, but there's not only BCVA, there is retinal sensitivity, where more points of macular function are being detected. And what we found in a prospective clinical trial is that intraretinal fluid is again the worst feature for clinical function, for retinal function. And this depends strongly on the volume. Next, please. Why is that so? It's because the functional elements, one back please, the functional elements, which are the photoreceptors, particularly the mitochondria-rich outer segments, which are visualized by the ellipsoid zone on OCT, are being damaged more by intraretinal fluid, less by subretinal fluid, even less by PED. For subretinal fluid, obviously, the current discussion shows that the jury is still out and we need to collect more data about the impact of SRF volume. But for intraretinal fluid, it's pretty clear. Next. it is also not just a short-term effect on visual acuity, it's also a long-term effect on irreversible alterations of the retina. And we know that it's intraretinal fluid that will strongly increase the development of retinal fibrosis, which is then irreversibly leading to visual loss. And this is so by a very large factor, around above 4 times more. As much as PED and subretinal fluid do have a negative impact on the development of macular atrophy, another irreversible feature that you want to avoid at all costs. Next, please. So how can such an important identification of fluid compartment and fluid volume be made accessible to the world? It is by using AI. Next, please. And the AI that we brought through MDR approval in Europe, this is shown here, is in this case based on the Heidelberg system and based on the HIX26 platform, but the same automated, reliable and reproducible AI-based measurement of fluid compartment and volume in a real-time manner is also accessible by RetinSight's app, which is integrated in the PACS or not. It's an independent WebEx tool. You click on the patient, you click on the visit. Next, please. The OCT is uploaded to the cloud, and in the cloud, the algorithm is searching for all the pixels that belong to a different compartment and a different volume. Next, please. So this is an example about a fly-through with annotation of the different fluid compartments based on RetinSight's fluid monitor. Next, please. What the result is, and this is, as I said, a real-time result, is that the clinician will obtain a fluid report that shows exactly from bottom to top here that the fluid was detected correctly. It shows an en face location where the fluid types are extending to. It shows the biography, the disease activity over time, and it gives you the exact volume in numbers so that every clinician can make a really reliable and consistent decision about retreatment and about disease activity. So this report can be obtained in Europe by MDR approval in any commercial setting, and in the US you need to inform your ethics board, but that nevertheless you can be assured that the algorithm is entirely precise, it's reliable, that data safety is provided, and that you can use a reproducible biomarker measurement. Next, please. So this is about fluid, which is a clinical biomarker, but there are other subclinical biomarkers which are most relevant, particularly the ones for atrophy, ellipsoid zone and RPE loss. Next, please. This can also be done by AI, and the AI algorithm here is much faster than even the fastest certified clinical reader, but takes only 1 to 2 minutes. And you can identify the area of RPE loss, which is always shown in blue, and the area of EZ loss, EZ meaning EZ loss, meaning that the photoreceptors are thinned out to more than 4 micrometers, which is the spacing in between B scans. So it cannot be detected anymore. It doesn't mean that the photoreceptors are gone, but it means, as we could show with targeted microperimetry, the visual function is lost, retinal function is lost to about half of its regular integrity. Next, please. We are accustomed to use fundus autofluorescence, but now there's enough evidence that clearly shows by comparing manual and automated FAF and OCT reading that on the OCT, the RPE loss reflects entirely what FAF shows us. But in addition, it shows the most important functional correlate, which is the photoreceptor, so EZ loss. Next, please. So why is this important? Because EZ loss is the most important activity marker for geographic atrophy, as is retinal fluid for neovascular AMD. Next, please. We could show by correlating the area of EZ loss, as shown here in two exemplary cases, where you have little EZ loss on the left side and a lot of EZ loss on the right side, that this is where RPE loss will expand to. So you can not only see at a single baseline OCT GA monitor image uploaded to the cloud immediately, so the patient comes in with the report in hands that disease activity is high by such a high blue to green ratio, but you can also see where exactly the atrophy is going to. So this reflects the disease biology. Next, please. And this has been published, and there is a clear correlation between disease activity and the ratio as shown here within the 4 quartiles. Next, please. This has a very strong effect on therapeutic efficacy. So as shown here in the study eye of the same patient, where you can also see the fellow eye, the patient's right eye, but the left eye is undergoing complement inhibition in the DERBY trial. And it is very clear that the progressive EZ loss is reduced, and that therefore there is no RPE, no fast RPE progression. Next, please. And this is exactly what you need to know when you are, one back, please, when you're doing treatment, because you want to select the patients that has disease activity. You would never give anti-VEGF therapy to a patient that has no fluid. You would never give atrophy inhibition if the patient doesn't have atrophy. And the atrophy is taking place at the level of the EZ area. And if this is a very active lesion, as you can see in the Q4 group, then you will very soon be able to see the difference between progression untreated and reduced progression treated. Next, please. But it is very obvious that geographic atrophy is a non-reversible and irreversible process. So screening matters. You have to treat early. You have to catch the patients as soon as the earliest signs of disease are present. Next, please. The earliest signs are small areas of EZ loss and mostly not related to visual acuity loss. So screening is something that AI has to do because the patients will not notice and they will not see the eye doctor. However, all of the patients are in an age group where they do see an optometrist and an optician. Next, please. And this is an opportunity that screening using AI can build on. And this is why we set up the Horizon Eye Screen trial, where people that are seen by opticians and optometrists by the use of AI are identified as having progressive and active intermediate AMD with a high risk towards conversion, or do already have the first signs of EZ loss. And this is when treatment has to start. Next, please. This, of course, cannot be built on spectralis OCTs. This has to build on all type of OCTs, particularly low-budget OCTs, which, however, are very efficient, such as the Maestro device. And this is what is used in the iScreen trial at 32 different opticians and optometry sites that are collaborating with 7 university hospitals, where we look on ONL thickness and subsidence, photoreceptor EZ thickness and drusen volume, and many other parameters in an automated fashion. Next, please. So to summarize what AI in the management of retinal disease can do, already now, AI makes robust insight available for optimized and efficient fluid management. It offers monitoring and patient selection tools that are most reliable and are based on subclinical features that eye doctors will have a hard time to recognize. AI introduces practical and reliable structure-function correlation. This is targeted microperimetry, which is also based on the anatomical map. AI introduces precision measurement into retinal disease diagnosis and treatment, which is most needed because this is the treatment that we do most in our field. AI allows shared screening and early detection, bringing in primary eye care as a most important contributor to maintaining visual acuity on a community base. AI facilitates and consolidates clinical trials to enhance the spectrum of diagnostic and therapeutic tools. It is a very reliable way to identify the efficacy of different substances, particularly in GA trials. And let's not forget that the clinical management that we do here is being done in one of the major healthcare challenges of modern times. Thank you so much for your interest.
Thank you, Ursula. That's really great. And we're going to have you stay on for the question and answer portion. I really appreciate it. For those watching, again, put those questions in the chat. We'll have our presenters or even our panelists discuss it during our panel discussion coming up. So I'm going to turn over to Dr. Ferrara. She's going to talk about artificial intelligence for the anatomical and functional correlation in GA.
Thank you so much. And it's a pleasure to be here. And those are my disclosures. So in the next few minutes, I'm going to share an extensive line of research that leveraged the cohort of patients that were enrolled in the well-known lampalizumab clinical development program. Even though this program did not meet its primary endpoint for the drug development, it has been enabling very insightful research in the last several years. And I'm going to fly through some of our main learnings using or not artificial intelligence to better understand anatomical functional correlation in this devastating disease. So what we observed in the last recent years is that the notion that geographic atrophy is a slow progressing disease doesn't really seem to be the case. What we found in this cohort, and that's aligned with many other cohort analyses, is that the vision decline due to geographic atrophy is devastating. We saw in this cohort that more than 3/4 of patients lost at least one line of vision by the end of the study. Half the patients lost at least 2 lines of vision, and even 1/4 of patients still lost 3 lines of vision. So certainly for patients with geographic atrophy, this does not feel like a slow progressing disease. Nonetheless, continues to be very hard for clinical trialists or physicians alike to understand at baseline or talking to the patient in front of them who are the patients at the highest risk. And Professor Smith's efforts just guide us through the bottom line of my presentation today. I'm going to show you how we've been designing clinical trials for the last decade, including the positive clinical trials that we experienced recently. What we found is that you cannot predict, looking at the best corrected visual acuity of patient at baseline, whether or not that's going to be the patient that's going to lose the most vision over time. In this cohort, for example, we saw that patients at baseline with unifocal and subfoveal lesions, they were the patients with the lowest visual acuity at baseline. And yet those are the patients that lost vision the most. So there's really no way to tell a patient, you lost enough, don't worry about it. We also know that visual acuity loss does not correlate with GA growth rate. And that's a problem for clinical trials because GA growth rate is the primary endpoint for drug development and clinical research. And again, going back to the baseline characteristics, looking at those patients that started with the lowest vision again, so patients with subfoveal and unifocal lesions, they are still the patients that lost vision the most in the lampalizumab cohort. So once again, the take-home message is it's very difficult without AI to look at baseline characteristics and predict without AI who are the patients that will lose vision. For those reasons, and also because best corrected visual acuity is such a noisy endpoint, in drug development, we've been selecting microperimetry as the most sensitive endpoint measure for visual acuity loss in drug development. We know how hard it is to implement microperimetry in clinical trial, though, if not impossible. Now, what our line of research has shown is that the standard visual acuity loss, even in microperimetry, are not sensitive enough for clinical trials. And main macular sensitivity, alongside with main absolute number of scotomatous points, has been historically selected at the main endpoint of clinical trials. That's just not good enough. This paper showed that perilesional sensitivity is likely the most sensitive microperimetry endpoint. But again, anatomical functional correlation is needed because we need to correlate the visual function loss with the primary endpoint for clinical trials. So our group of research, just like any other group of research at this point in time, has been leveraging artificial intelligence to measure geographic atrophy at baseline and progression over time. So the next series of papers that I'm going to discuss leverage an in-house algorithm that was developed to measure GA lesion. And I want to call your attention to the sensitivity of those and performance of the GA segmentation algorithm in different imaging modalities. Not all algorithms are created the same. In this case, this prototype had excellent correlation with human experts in most of the cases, but this algorithm fails like most algorithms fail in some cases as well, and that's critical for clinical trials. So algorithm performance is critical for clinical trials. One take-home message, though, is that in most cases, this prototype failed when image quality was also not good. So algorithms and humans fail when image quality is not good. Image quality collection needs to be critical for the reliability of AI outputs. Another learning that's important for clinical trials is that when we look at using deep learning to segment geographic atrophy area at baseline, and we compare that segmentation with the best highly trained humans of our disposal, we see that when we look at the correlation between algorithms and humans at baseline, a cross-sectional correlation, it's very high and it's very good. Nonetheless, when we look at how algorithms perform over time, and when humans perform GA progression segmentation over time, the correlation may not be that good, even when we're using our highly trained humans, which begs the question, who's really right, the algorithm or the humans? Now, while GA segmentation is truly transforming clinical trials and clinical research, and now it's transforming clinical care of patients with geographic atrophy, truly the holy grail in GA is to predict at baseline future lesion growth. Just because this is, again, the primary endpoint of clinical trials, and it's what physicians care the most when they're deciding how to manage their patients. So in the next series of paper, what I'm going to show is a prototype algorithm that leverages fundus autofluorescence at baseline or OCT at baseline or a multimodal approach to not only segment and measure geographic atrophy area, but also to predict future growth. And what you can see here is, regardless of the imaging modality that this prototype uses, the performance is quite similar. On the one hand, this is useful because fundus autofluorescence is just easier to collect at scale, especially by less trained operators. And nonetheless, it's a two-dimensional assessment. So as a clinical researcher, I was disappointed that the OCT GA growth prediction was not better than the UNFAS FAF growth prediction. So I'm going to go back to that concept in a moment. Another important take-home message is that we leverage deep learning as our best modeling approach. But as a clinician, I'm slightly uneasy when I really don't know what the model is looking. So this research group and several other research groups have been leveraging techniques such as heat maps and attribution maps to better understand what deep learning is looking. And in these examples, the first row shows a model that's looking for GA progression. So it's looking at the borders of GA as it should. And in the lower row is a model that's looking at GA area and is looking at the area of the lesion as it should. So the take-home message is transparent and understandable AI for clinicians is also important. In this other experiment that we published recently, we used a different technique to, if you will, open the black box of deep learning approaches. And we looked into the contributions of different pixels of the FAF image to predict GA lesion growth. We look at the lesion, the borders of the lesion, or the rest of the background of the image. And in a series of experiments, we simply played with the pictures and with the pixels, and we learned that, of course, when we use the complete fundus autofluorescence image, the algorithms perform the best. when you start to remove or to add pixels in the regions of interest that I mentioned, the algorithm performance starts to go down. And when you completely shuffle the pixels around and you remove from the algorithm performance the correlation between brightness and darkness, the algorithm starts to perform less. And when you completely remove the brightness of the FAF, that's when the algorithms have the lowest performance. Now that we established that AI can measure GA lesion and AI can predict future growth better than humans, the next question is, can AI predict where exactly new GA lesions will appear? And the answer again is yes. You see in those 3 rows, different modeling approaches, and you see in the green lines where the lesion actually grew based on human expert segmentation. What you can see in the red lines is a prediction of growth AI-based using deep learning modeling approaches. So very powerful technology, again, that can do things that none of trained experts like myself could possibly dream of doing. Nonetheless, even though we're very excited, we continue to explore different modeling approaches in trying to improve the performance of those algorithms. And this is a very busy table, but the take-home message here is that trying different modeling approaches in different data sets, the correlation, the Pierce correlation or the dice score, it doesn't change that much when we trained with different modeling approaches or test different modeling approaches. And then we started to ask, what can we do better? It goes back to a concept that I mentioned earlier about ground truth. When we look at the ground truth that we used for these models, and you look at the greater agreement, and this is the agreement across some of the best and brightest human-trained experts worldwide, their correlation is good, but is also not as good. So take-home message is ground truth for training is also critical. Now, going back then to finalize, going back to the value of using 3-dimensional OCT documentation rather than bidimensional fundus autofluorescence segmentation, I'm going to share a couple of final papers for today and guide you through some of our final take-home messages. In this work, we used different modeling approaches, different CNNs to perform, again, understand how deep learning can help us predict GA area and GA growth rate. One challenge, though, in using 3D is the pre-processing of images. And even though that's out of scope for today's talk, it is an important learning that depending on the imaging modality that you are leveraging for your algorithm, the backstage efforts to prepare an image can be much harder than the modeling themselves. Algorithms are the tip of the iceberg. Nonetheless, we continue to pursue OCT-based research because, as Professor Smith-Efford mentioned before, it does give you access to specific retinal layers that are really important in this disease progression. And in a nutshell, what we learn in this very thorough sequence of experiments, training different CNNs using different unfast segmentations of different layers of the retina, is that when you're looking for GA area, really doesn't matter which retinal layer you're using to measure or to predict the lesion area. But when you're looking for disease progression, that's absolutely key. And if you're looking to different OCT layers, your capability or capacity to predict GA growth will be different. So we have to leverage 3-dimensional documentation to make a powerful prediction of lesion growth. And to conclude, I'm going to share the most recent endeavor in establishing an anatomical-functional correlation, as Professor Smith-Efford mentioned. And we use for this prototype, this series of experiments, a prototype algorithm that measured 3 key retinal layers. And to conclude, I'm going to show our best corrected visual acuity and low luminance visual acuity and low luminance deficit correlation with that powerful OCT segmentation. What you can see briefly is that when we segment OCT of patients with GA at the level of the external limiting membrane, you have the best correlation with the best corrected visual acuity as expected. Now, what helps us the most is not only a segmentation in the level of the retina, but also a segmentation of specific regions of the macula. So similar to take-home message than microperimetry, when you look at all points, BCVA is just too noise. But when you look at specific areas of the macula, then you can start to establish anatomical functional correlation, even in an endpoint that's so noisy as BCVA. Continuing this very insightful research, when we look at the ellipsoid zone loss, so photoreceptors loss, what we found is that the highest correlation is not with BCVA, which is a very noisy and group response. When you look at LLVA, we start to see better correlation between ellipsoid zone, so photoreceptors loss, and low luminance visual acuity, which also makes sense with the biology that we know about the disease. And finally, when you segment only at the level of the retinal pigment epithelium, but not at the level of the photoreceptors, then if you look at the very center of the macula, that's our best chance to establish anatomical functional correlation. That's one of the reasons why the main clinical trials, including the clinical trials that approved the drugs that we have now for GA, had a really hard time to establish anatomical functional correlation. So I'll conclude really thanking my co-authors. It's been of the brightest and smartest and kindest people I ever had the chance to work with. And many thanks also to our expanded and extensive research collaboration across this fantastic organization, as well as our collaborators across academic centers worldwide. Thank you so much.
Thank you, Daniela. That was a great presentation. And again, please feel free to submit questions in the chat. We're going to get to them during our Q&A session. I'm going to turn her to Dr. Hazatsevich. She's going to talk about deep learning framework for predicting treatment initiation for neovascular AMD. Thank you, Maja, for joining us.
Hi, everyone. It's a pleasure being here today. Both of these talks were amazing, so it's going to be very difficult to follow up. But anyhow, I'm going to try. I'm going to be talking about a new deep learning framework to predict when to inject patients with neovascular AMD. This is a work in progress that my team has been working on. I'm coming from Duke. This is supported by the NIH grant. So all of us, we know how important it is to start treating patients with neovascular AMD in a timely manner. And we know that actually 2 weeks is that window when we need to treat so that we can preserve good visual outcomes. And thus we were thinking, can we develop a fully automated system to determine when is the best time to inject patients with neovascular AMD? Based on the OCT image biomarker features and the visual acuity scores, and that was our task 1. And our task 2 was to try to develop a deep learning approach that will extrapolate outer retinal thickness, in our case Bruch's membrane, to the outer plexiform layer, as we thought that was important part of the retina for the neovascular AMD, as a image biomarker, so that we can actually follow up the progression over time. So what we did, this is a retrospective study. We actually went to the Duke electronic medical records and pull out all the patients that had more than one, at least 3 actually, consecutive visits at Duke that had a baseline diagnosis of intermediate dry AMD. We pull out about 2,000 OCT images, and then we split it into 2 data sets. And I'm going to go in more detail why 2 data sets. Data set 1 was used for the first module, and data set 2 was used for 2 other modules that we have in our approach. We were using Heidelberg Spectralis OCTs. We were taking time of the initial anti-VEGF injection as the ground truth for conversion to neovascular AMD. Volume scans were used, and it was a middle 31st B scan in JPEG compression format. We were resizing it to the size that would comply with the input dimensions of the previously developed CNN architectures that we had. And in general, you can see in the table that the number of patients and the way of the randomization was pretty uniform, including the number of the patients that converted to neovascular AMD. So this is a busy slide. I'm going to try to make it simple. So as I said, we were looking into two tasks. The first task was to see when to inject patients that have converted to neovascular AMD, and task two is to extrapolate outer retinal thickness as an image biomarker and predict changes over time. We had three modules. Module one was extracting image features, subretinal fluid, intraretinal fluid, including outer retinal thickness, and correlating them with the visual acuity scores, looking for the time point when to inject. Module two was using findings from the module one and task one, long-term prediction of the disease progression, and module three was looking at the changes in the outer retinal thickness over a prolonged period of time. We actually had two long short-term memory models that were trained on separate data sets to accomplish these two tasks. And here, this is a performance comparison. As what we usually use in this case, we were using similar performance metrics. The most important ones, we were using confusion matrices. We were using area under receiver operating characteristic curve. We were using precision recall curves as well. And we were actually comparing our work, our framework, versus the baselines that were available. Baseline 1, which we call baseline A, excluded global average pooling features from the OCT images, and baseline model B was using the visual acuity as an input for the algorithm. And what you can see here, you can see that we have a model performances divided into two, a single visit assessment and a sequential assessment, because these patients have been followed over a prolonged period of time. And rows of the confusion matrices represent the ground truth labels, and the columns represent model prediction. And you can actually see in a ROC curve and also a precision recall curve that our model outperformed the other two models. So these are some of the details how we did in comparison to the other models. So our model on a single visit assessment as well as a multiple visit assessment sort of outperformed the other models in the precision. The only thing that we were lacking looking at all of the data sets was sensitivity. We do believe that sensitivity was suboptimal because of the imbalanced data sets, and we are actually trying to fix that now. And this is another portion of the results showing the sequential assessment. And again, we are in the precision and other important metrics outperforming other models that we were compared to. This is another interesting thing that we did. We were pulling out patients, and we wanted to follow up over time and see whether our model can predict where the outer retinal thickness is gonna be in the function of time. You can see that the blue bars are the ground truth bars. Green bars are actually outer retinal thickness features extracted by the algorithm, and orange bars is the future of the outer retinal thickness as predicted by the module 3. There are some discrepancies, but in general, actually pretty good overlapping between the orange and blue bars. Finally, when we were actually doing a normalized mean absolute error for the outer retinal thickness prediction over a period of time compared to the ground truth, it was about 0.12, so that's actually pretty good. And when we did a Pearson's correlation coefficient, it actually turned out to be pretty strong in about 0.73. So in general, this is still a work in progress, but our work suggests is that a fully automated deep learning framework can be used to effectively predict the timing when to start injections in patients with neovascular AMD and fresh conversions. And also we can actually use this framework to try to predict where the outer retinal thickness is going to be in the function of time. I think this is important not only for neovascular AMD, but also for the geographic atrophy. As I said, this is a work in progress. We are fine-tuning, especially fine-tuning sensitivity results while working on the resampling to improve the imbalance in our data sets. And I want to thank to everyone here, this amazing panel of people that I'm actually humbled to be with today. And also I want to thank to my team of grad students and collaborators at Pratt School of Electrical Engineering here at Duke. So thank you very much.
Great presentation, Maja. Thank you. And you stay on for the Q&A, please, and we'll get to questions. There's some great questions coming up in the Q&A box. And next presentation will be Dr. Alexandra Rachaskaya. on predicting predicting geographic atrophy growth in real-world settings.
Thanks so much, Rishi, and so wonderful to be here with all of you. I echo the comments that it's a fantastic panel. So I'm going to talk about GA prediction growth in real-world setting, and I would like to acknowledge my co-authors, including Dr. Rishi Singh and the team from Apellis. In terms of disclosures, I worked as a consultant both for Apellis Pharmaceuticals and Astellas. So as we have new treatment options for GA, more and more we need to identify and stratify patients at risk of GA progression. And this gap is what led us to do this study, where we aim to develop a time-to-event risk calculator to predict time to key outcomes based on patient characteristics that are actually available at the time of GA diagnosis in routine clinical practice. The two key outcomes studied were the time to event for subfoveal involvement, as well as time to severe visual impairment, which we defined as Snellen score of 20 to 100 or worse on 2 or more visits. Once we developed these prediction models, we wanted to validate it using clinical trial population. And so to do this, we used the electronic health records of patients with GA seen at Coli at Cleveland Clinic. And we developed a series of risk equations estimating time to event outcomes. As I mentioned, we purposefully wanted to look at some of the variables that are available to clinicians in any clinical situations, and those included age, sex, baseline visual acuity, subfoveal lesion location, smoking status, presence of the disease in the other eye, and comorbidities. And then we produce these predictions of time to subfoveal involvement and separately time to severe visual impairment. And then we did the validation using the sham patients who were observed in OAKS and Derby trials. To get included in the study from Cleveland Clinic dataset, we had patients who had 2 or more VA measurements from baseline, had all the baseline key risk factors that we were studying, and Snellen VA better than 20 to 100 at baseline. So to do the analysis, we looked at the Cox proportional hazards model of time to event outcomes. And then to test the internal predictive accuracy of the models that we've created, we used area under the curve as the measure of the ability of the equation to discriminate patients with or without the event, and concordance, which is the probability of correctly ranking patients by time to event outcomes. When we wanted to compare our risk equation predictions for patients with the baseline characteristic profile of sham patients to the observed progression of sham patients to key events, we used calibration, which is visual assessment of how closely predicted time to event curves aligned with observed outcomes. So as we look at the population of patients from Cleveland Clinic, you can see that these are standard GA patients that we see every day. Our average age was 82, mostly females, majority Caucasian. The baseline visual acuity was 20/55. 46% had subfoveal lesion, GA in the fellow eye in about half of the patients. 7% were current smokers, and here you can see the comorbidities, including hypertension, diabetes, chronic kidney disease, coronary artery disease, and hyperlipidemia. And we did exclude patients who had neovascular AMD. When we look at the predictability of subfoveal involvement, we see there was most impacted by baseline distance from the fovea, visual acuity, GA in the fellow eye, age, and smoking. We had the area of under the curve of 0.72 that was achieved with these risk factors, and increasing the number of risk factors didn't improve performance of the model. When we look at predictability of time to severe visual impairment, it was most impacted by baseline subfoveal status, sex, visual acuity, age, smoking, hypertension, and diabetes. Area under the curve of 0.72, and once again, increasing the number of risk factors didn't improve the performance of the model. So now that we have this model, we wanted to validate it using the OAKS and Derby sham sample. Clinic sample had 410 patients. OAKS and Derby sample had 338. If we look at the baseline characteristics, we see that OAKS and Derby sample had slightly more advanced disease, slightly worse vision, more subfoveal lesions, and more GA in the fellow eye. Also, the way we assessed smoking was different. In our sample, we used if the patient was a current smoker, and in the OAKS and Derby, it was tobacco use ever. So that's why you see such a different percentages there. So when we look at the time to subfoveal involvement, the observed and predicted outcomes were highly correlated out to 24 months. And here you can see high and low predictions that were generated by adding or removing that smoking risk factor, since it was collected differently for these populations. But observed and predicted 24 months estimates are within 4 percentage points of each other. When we look time to severe visual impairment, we see that the curves are very close up to 12 months, but we see divergence from 12 to 24 months. And what we identified is that there was two sources of diverging progression, including patients with more than 2 severe vision loss measurements in the first 3 months, and also patients who withdrew from the trial. When we relax the sensitivity to reflect these differences, it makes the model strongly predictive out to 24 months. So what does this mean? Well, the progression to subfoveal involvement predictions, when we look at clinic and OAKS and Derby data, were nearly identical after adjustment for baseline risk factors. And important risk factors that we identified for time to subfoveal involvement included baseline distance to fovea, visual acuity, GA in the fellow eye, age, and smoking. Progression to severe visual impairment identified as visual acuity of worse than 2200 had similar risk estimates of clinic and OAKS and Derby data after adjustment for baseline risk factors and factoring in differences in data collection frequency. Important risk factors for time to severe visual impairment included baseline subfoveal status, sex, visual acuity, age, smoking, hypertension, and diabetes. Validation of the models with OAKS and Derby sample showed high consistency in predicting progression outcomes and allowed for generation of the GA risk calculator utilizing the data that's available to clinicians in a standard clinical practice. I thank you so much for your attention, and I thank the organizers for opportunity to present this data. Thank you so much.
Thank you, Dr. Rajiska. Wonderful presentation. So we're going to turn over to our next presenter, who's going to talk about the evaluation of geographic atrophy, lesion measurements and growth rates using a semi-artificial artificial intelligence pathway. This is going to be given by Dr. Becleru, and thank you for Dr. Becleru for giving this presentation.
Thank you so much. As introduced, my name is Sıla Bekiroğlu. I'm a medical assistant in Swiss Vision Montjoly, and I will be presenting on behalf of Dr. Odd Ambrozan today, who is unable to attend. So monitoring geographic atrophy has become increasingly important with the development of new therapeutic options for dry AMD. However, manual treatment remains time-consuming and variable. Thus, traditional geographic atrophy lesion measurements relies on semi-automated fundus autofluorescent-based tools, such as Region Finder, which is the gold standard method. However, advances in AI-driven solutions such as Retina AI Discovery allow for fully automated analysis based on OCT scans. While AI algorithms may improve efficiency, their accuracy and reproducibility need to be validated against the already established methods. Our study aimed to compare Region Finder and Retina AI Discovery methods by comparing lesion areas at baseline and last follow-up, and by comparing annual growth rate of GA lesion areas. It also aimed to assess Retina AI Discovery GA prediction tool compared to real-world measures. This was a retrospective monocentric study with 33 eyes conducted in Swiss Physio Retina Research Center. Our inclusion criteria were GA secondary to dry AMD with RORA on baseline OCT, and eyes with neovascular AMD were excluded. Lesion measurements were obtained using both tools and then compared. Lesion growth rates were calculated as the difference in lesion area between visits divided by the time in years. The artificial intelligence predictions at 6 months and 1 year were then evaluated against actual follow-up data. Here we can see the lesion area comparisons per eye. When looked at the whole cohort, it was seen that artificial intelligence consistently measured larger lesion areas than Region Finder. This difference is likely stems from the segmentation method and imaging modality used between the methods. And despite these differences, correlation between the two tools was strong at both baseline and follow-up, demonstrating the two methods are closely aligned in their assessments, actually. When looked at the growth rates, those measured by artificial intelligence were again seen to be higher. However, the correlation between the two methods still remains strong, indicating both methods are reliable for tracking disease progression. We also tested Retina AI's GA prediction tool, which estimates future lesion sizes based on a single baseline OCT in terms of lesion sizes and growth rates. Lesion size predictions of Retina AI were compared to actual sizes from OCT scans at 6 months and then 1 year. The absolute errors observed was low, and they fell within the acceptable range reported in the literature. Regarding the growth rates, the predictions showed more variability, likely due to sample size and outliers, but the model still managed to capture the general trends. The results of the regression analysis showed that although some variability was present, the algorithm showed a reasonable alignment with actual lesion evolution over 6 months and 1 year, and that the predictive model appears capable of estimating general progression patterns. To conclude, AI consistently measures slightly larger GA regions than Region Finder, likely due to differences in imaging modalities. Both methods showed strong correlation in measuring lesion area and growth rates, and that the artificial intelligence prediction tool effectively captures general lesion growth trends, but further validation is of course needed with larger cohorts. With larger cohorts. Thank you for your attention.
Thank you. Thank you for giving that presentation. Really appreciated it. And we're going to have you stay on for the question and answer portion. Our next talk is going to be by Amita Donapalli. She's going to give a talk on the performance and feasibility of AI model and RP loss quantification and OCT imaging for GA. Amita?
Thank you. Thank you to the organizers for this great opportunity. I'll be talking essentially about implementation of AI models for OCT GA area measurement. Okay. I have no disclosures. And all the speakers before have talked about how important OCT endpoints have become for GA, especially for photoreceptor loss measurements and RPE loss measurements. And this is extremely complicated for humans to do because the RPE loss or CRORA criteria go through every single layer of the retina And then you have to go through every single B scan, and quantification can become a nightmare and time-consuming process. So we do need AI models that are required to do this measurement. So the purpose today is to talk about how do we implement these as a tool for measurement in reading center workflow, and how can we understand integration, feasibility, greater burden, and all the implementation challenges that we have. I won't spend a lot of time on model training and curation and all that, but to be brief, we're used to hearing about segmentation models, layer segmentation. All of us know about that. We've been doing that for decades. But for this particular curation, we used an edge detection method, which means the graders go through the layers, identify areas of CRORA or RPE loss, and do a horizontal line to identify the end of RPE loss to the other end of RPE loss across a scan. So that's called edge detection. And that edge detection gets translated to an on-FOSS map to create these areas of GA. And we developed a 3D model to identify this area. So the model was trained, and then we tested it on an independent data set, longitudinal GA data. You can see here that the graders measured 7.3, AI measured 7.2, pretty close. Dice coefficient was 0.877. Bland-Altman plots are pretty tight, a few outliers in extremely tiny areas. But this is essentially the human measurement on FOSS, and then the AI prediction on the side. You can see the correlations are pretty good. They're pretty good, but pretty good is not enough when something is an endpoint for a clinical trial, and the measurement and the study output depends on it. And this, if I was writing a paper, this would have been good enough. I would have concluded model performance was pretty good and all that. But for implementation purposes, we need to go beyond this. So we need to know, well, what are the performance metrics for operation? How often does a grader have to edit this AI prediction? And if they do have to edit, how much effort is needed to edit this AI prediction? So the standard metrics are great to understand and set benchmarks and compare models and publish and speak the same language. But for implementation, we need to know the environment in which it's being implemented and what sort of accuracy does it need to have. So this is a quick video of how the model performs. Let me see if I can launch this video. This is what the grader does. They go into their viewer, they pick up an image, and they run a gear. And a gear is nothing but a Dockerized, it's a model that's been placed as a plugin. The grader says, okay, I want to run an OCT gear and on this particular image, and they run the gear and take a few minutes, and then the model will run in the background. And after that, they get their application all done. And then once that is done, they go into the viewer, and they get to choose which gear they're running. So here the AI has run. The grader can review all the measurements that the AI model has performed, check if it's correct, edit if it's needed, remove wrong measurements, increase areas that have not been measured. And so they get to review and edit everything that the AI has done. So this is a semi-automated tool for the grader to use, which is AI-based. So it's very useful for us to think of this practically for implementation. So we said, well, we're going to classify this as 4 levels instead of dice coefficients on everything. Score 1 is where it's excellent, no edits are needed. 2 is minor edits, takes about 1 to 2 B scans or maybe less than 2 minutes. Fair is when they have to do major edits, and poor is unusable, and then you have to start from scratch. And we had predefined thresholds for implementing an algorithm for a semi-automated use, which was very similar to how a grader would get certified. So to be accurate, a grader had to have at least more than 70% of their segmentation or annotations had to be in category 1 or 2, because everything gets reviewed by a senior grader. So senior grader, when they review, they say, okay, you are good enough, you're more than 70%, you can get into production. So that's how the AI is measured also. And so that's our criteria. And here are some examples of score 1, where The model performed well, no edits. Bottom left is score 2, where the model had some minor edits, but it didn't take too long for the grader to clean that up. Score 3 took a little longer than just 2 minutes, and score 4, where it missed most of the lesions, so the grader had to do most of the work again. And really, there's no point if you have too many score 3s and 4s to use an AI model to measure things. So in this case, we found that about 77% were in that score 1 to 2, which was well within what we were thinking of. And when we looked at the DICE coefficients, they seem to flow pretty well with this scoring system that we were using for implementation. So there is a correlation between the two. We also look to see, well, does it change by morphology? And yes, the best performance is in unifocal subfoveal lesions, moderate performance in multifocal, and the graders know that, have been told, hey, watch out if it's an extrafoveal lesion, there's more errors, so clean those up a little better. So implementation-specific workflows and efficiency metrics must continue to guide integration. So you need to know, how do I make this workflow work for our particular use? And this is kind of our deployment pipeline. Once the image quality of check, some of which is AI-based, the images are ready to grade. A pertinent AI model is deployed by the grader, depending on the image, the endpoint, whatever they need to measure. And then they review the output, the edit as needed, which is extremely important because a lot of models stop here where model is deployed and we don't have an editable platform. And that is much needed to have the accuracy for endpoint measurements. And once all that is done, all the measurements are generated, entered into databases for analysis and FDA approval submission. And the real journey begins with implementation. So thank you.
Thank you, Dr. Donapalli. Really appreciate it. Just stay on for the Q&A and we'll get to you at the end. So I want to introduce our keynote speaker for today's program, Dr. Malvina Elliman. Thank you, Dr. Elliman, for joining us. I know you're speaking on the collaborative communities and ocular imaging and AI initiatives. I just wanted to give you a word of a little bit of background on Dr. Edelman, if you don't mind. She's obviously shaped device market approval for many years for both eye, ear, nose, and throat. So you've had multiple different areas therapeutic areas you worked in. You've had a lasting impact on the medical device regulation field, and particularly concerning these areas. And you really have made a great effort to bring innovative medical technologies that are both safe and effective to our patient care. So wanted to appreciate you and thank you for your talk today, and I'm looking forward to it.
Thank you very much. It's a pleasure to join this illustrious group once more. And today I'm sharing my thoughts as a CEO of the collaborative community on ophthalmic innovation. Collaborative community on ophthalmic innovation is driven by a bold mission to remove every barrier standing between groundbreaking ophthalmic innovations and the patients who need them worldwide. We exist to accelerate the future of eye care. As all of the speakers this morning have summarized, AI/ML-enabled medical devices have wonderful opportunities, but at the same time still present a number of challenges. We heard that AI allows for earlier disease detection, more accurate diagnosis, personalized diagnostics, therapeutics, and an ability to learn, adapt, and improve performance. However, we have also heard from a number of speakers today challenges of fit-for-purpose data sets for development and testing, identification and minimization of bias, opacity of some algorithms, and need to ensure transparency to the users. With that in mind, global regulators recognized the need for careful oversight to ensure that the benefits of these advanced technologies outweigh the risks to all of the patients around the globe. Specifically, the 4 areas that we all must focus on is usability, trust, equity, and accountability. Back in 2013, International Medical Device Regulatory Forum, or IMDRF, have come together to put a key series of documents for software as a medical device. The very first key document that has been generated by that group was a foundational vocabulary all the way in 2013. And I truly believe that had it not been for that document, we would not be as a society where we are in healthcare with AI. In 2014, this group proceeded to generate risk framework based on impact to patients. 2015, quality QMS, which was translating software development practices to regulatory QMS. And then it followed by a recommendation for clinical evaluation for software as a medical device. This group then proceeded to align approaches specific to artificial intelligence enabled medical devices. And in 2022, they put together a document for machine learning enabled medical devices, key terms and definitions. They continue to work, and I would like to bring everybody's attention to two very recent documents that this group generated, both in just a few months ago. One is on characterization, consideration for medical device software and software-specific risk, and another one on good machine learning practices for medical device development, the guiding principles. I have referred a number of times to the IMDRF, but I wanted to give you a pictorial representation of all of the active members that are depicted on the slide. And the sole goal of this forum is to accelerate international regulatory convergence. And as I mentioned, this group has generated some of the most important documents with respect to SAMD and AI. However, a subgroup of the whole IMDRF generated two key documents that I want to highlight for this group today. One of them is the document that was published by US FDA, UK, and Health Canada in 2021. And that document outlines the 10 good machine learning practices for medical device development, the guiding principles. The principles are intended to promote global harmonization and encourage broad stakeholder engagement. Likewise, the same subgroup of 3 countries in 2023 published the guiding principles for change control plans, which outline key characteristics of robust PCCPs to support changes to AI-enabled devices while ensuring ongoing device safety and effectiveness in cases where regulatory authorization might typically be required. Now, over the years, FDA has put together and published quite an extensive summary of guidance documents. What I'd like to highlight is a document that came out just in December, which summarizes and mimics what IMDRF did on PCCP. It's the final document for marketing submission recommendations for predetermined change control plan for AI-enabled device software functions. And just a month after that, there was another very important draft guidance, which talks about the recommendations for comprehensive approach to the management of risk throughout the device total product lifecycle of AI-enabled devices. Now, how does all of that relate to CCOI? Well, CCOI's goal, plainly, is to translate everything that has been done on a global scale to translate it specifically to ocular imaging with the sole goal of expediting access to safe and effective AI ocular imaging worldwide. And we intend to accomplish our goal with 4 pillars. One is to develop foundational principles of AI in ocular imaging, to establish gold standard endpoints for efficacy assessments, to enable reimbursement pathways, and to scale utilization. With respect to developing of foundational principles, we will maximize utilization, as I mentioned, of established horizontal international consensus and available global regulatory guidance, and continue to ground principles in ethical framework while quantifiable ethical metrics. As a number of speakers mentioned, it is essential for us to have gold standard endpoints for efficacy assessments. In the ophthalmic space, we're working in diabetes, AMD, myopia, glaucoma, cornea, cataract, to name a few. But I also want to highlight our very strong emphasis on oculomics. In the upcoming year, we intend to put a lot of effort in establishing gold standard endpoints for utilizing AI ocular imaging to diagnose neurologic, cardiovascular, and renal systemic conditions. We are putting together a very strong working group that will allow us consensus for standards for outcomes research to support reimbursement, and a consensus and developing a consensus framework for developing the AI charge, maximize reimbursement transparency. A couple of speakers also alluded to the fact that while there are a number of AI devices out there, the utilization hasn't really been up to what we would expect. And to maximize the utilization of this fabulous devices, what CCY plans to do is to put tremendous emphasis on patient education, physician education, optimizing workflow implementation, and once again, making sure that we have clear reimbursement pathways going forward. Many of you have partaken on our conferences, and we're very proud of how we've grown. The last conference had about 1,300 registrants from countries all around the globe. But in addition to our annual conferences, we have made a number of other accomplishments to date. There are some key publications, just a couple of which I'm highlighting on the slide. But we also have a contract from FDA via a BAA grant to enhance visual health in underserved populations via novel real-world health data sets, utilizing ophthalmic imaging and artificial intelligence. And we're also working on a number of registries, one of which is led by Amitha, and I'm glad she didn't use, this is one of her slides, and I'm glad she didn't use this particular one, but under her leadership, we're collaborating, CCY is collaborating with Amitha to do this tremendous registry to benchmark data set for AMD screening. This map just highlights exactly what CCY is all about. We truly intend to penetrate worldwide. And just as the sites for registry show worldwide distribution, that is truly correlates with CCY's intent to make sure that we expedite innovation in every part of the world. We have grown extensively. As you can see, we have many work groups, both horizontal and vertical. And with this tremendous growth, we intend for all of the work groups to launch AI-driven initiatives over the next year to advance ocular innovation with a goal to expedite access to safe and effective AI ocular imaging worldwide. And I want to thank many, many members of CCY from around the globe that have come together to make sure that we truly collaborate as one ophthalmic entity to assure that we have safe and effective eye imaging with AI globally. Thank you for your attention.
Thank you, Dr. Element. I really appreciate that. So we're going to bring all our panelists up for this Q&A session, and we have a few minutes to kind of comb through some of these questions, which are really wonderful. People asked a lot of great questions here. So love to kind of throw this out to the entire audience. You know, we talk a lot about imaging and what we do in prediction. We've now focused so much on things like proteomics or even genomics as part of this. And I wonder where you see the interplay between this. You know, there was a recent study by Mass Pioneer that showed that proteomics in 5 to 6 proteins had a strong prediction in GA growth, yet, you know, it wasn't, you know, we haven't coupled that with the imaging. So are we missing an opportunity here, or is it all imaging all the time?
If I can take a stab.
Yeah.
So this is, you couldn't have asked a better question. So we truly, you know, CCOI is truly focused on maximizing every possible opportunity for a biomarker to expedite innovation. And in our oculomics group, we actually have 2 co-chairs who have very different hats. And one is taking the hat of ocular imaging, and the other one is specifically focused on everything that you've just discussed and trying to see how with the oculomics work group, we can maximize the input from both aspects, utilizing their very unique expertise to combine and optimize the speed of innovation.
And Rishi, just adding to this, of course, for exploratory, cutting edge, translational research, AI also help us to combine different data sets and multimodality data sets. So absolutely, we want to correlate different types of data. I think it's important, though, as we do that kind of research, to be very focused on the use case. So if you're doing translational research for new target discovery, new MOAs, then absolutely, the more data, the merrier. It's important, though, that that translates into actionable solutions, because we're not going to be able to use all types of data when you are looking at the patient in front of you and deciding if you want to enroll that patient in a clinical trial or if you want to treat that patient. And I also think AI is going to help us to do that, to translate understanding and scientific insights into very user-friendly tools.
I think that you mentioned a very important point, which is actionable. And what is actionable in retina are the biomarkers of our target organ, which is the retina. And we are just learning about the meaning of biomarkers as important as the EZ layer, the EZ thickness, and the EZ loss. So we are learning that precision matters, that you really have to be extremely precise and you cannot have unreliable reproducibility. The other point that we are just about to learn is the structure-function correlation, because a relevant biomarker is a functionally relevant biomarker. And for the EZ loss, what we were able to show by using data from retrospective microperimetry assessment, as has been done in the OAKS trial, to the largest dimension that we have, and also prospectively with developing a targeted morphology, that means biomarker-driven functional assessment point to point, and that we could provide proof of principle that that EZ thickness correlates directly and in a linear fashion to function, that with every 1 micrometer thinning of the EZ layer, 0.2 decibels are lost in this specific spot. This makes biomarker assessment truly meaningful.
Yeah, I wanted to open it up to you all. You know, we've talked about the world of oculomics, and I'm glad to see, Melvina, that your group is taking a very proactive approach to this, because I think that the question always in my mind now as a healthcare administrator is who's paying for this work that's being done. So, you know, I would like to hear other people's thoughts on sort of the application of oculomics to systemic diseases in general. I know that a couple of you have touched on this. Some of your work maybe not be presented today, but just like to hear kind of your thoughts on sort of that standards we have to set for it. What are the standards that are going to be there that we really need to have? This is more of a theoretical question than anything else. Love to hear maybe from Malvina first, and then we'll open it up to everyone else.
Thank you for the opportunity to comment on this very important topic. So, from my, what I like to call the helicopter view, the most important thing is to make sure that we look at the input and the output. So as far as the input, we need to make sure that we clearly define the minimum requirements for image acquisition, because as all of us know, garbage in, garbage out. So we need to make sure that the images which we capture to make these diagnostic criteria are adequate and can truly be utilized for AI without generating erroneous conclusions. So that's one of the groups, that's one of the four things that actually CCY is working on to make in the area of oculomics, coming up with a consensus of minimum requirements for image acquisition. Then on the outside, we need to know what the thing puts out, whether it's really correlated with the disease. So in order to do that, you need to work with our colleagues in the respective fields. For example, in neurology, in CCY, we just within the last couple of months, we've established a very strong relationship with patient organizations in Alzheimer's, in Parkinson, in MS, to make sure that all the work that they have done to diagnose and predict progression of the neurological diseases is actually consistent with what what the outputs of our AI systems are. So again, input, output, and then patient penetration and reimbursement need to be happening in the background in order to make sure that when we're ready, patients are ready to accept it, and that patients can get it because we have a path for reimbursement.
Mm-hmm. Any last comments on that topic? I'd love to hear from anyone else.
I think that one important issue is specificity for biomarkers that are relevant in systemic disease, because the retina is showing changes at the vascular level, as we know, and at the neurosensory level. But most of the biomarkers that we measure in systemic disease are not specific, or I think there's no specificity proven for being able to use this for screening, for instance, which is most important in systemic disease. So Malvina, what do you think about the level of specificity, the evidence of specificity that we have accessible for systemic disease?
Well, that's part of the gold standard endpoints, as Amitha knows very well, having gone through this exercise with AMD, as you know, being part of the AMD. When I talk about endpoints, we talk about specificity that you need in order to detect that. In my mind, that's not separated. Because when we talk about AI, we talk about the endpoint and the specificity with which that endpoint is produced.
Yeah.
Very much so.
Great.
And real world prospective assessment needs to be shown in not just an independent test set that you've got to hold on, but that's so important for these oculomic studies.
Yeah.
I'm going to just chime in. I think precision medicine is going to be the future, and we're going to probably very soon include genetic makeup of the patients in the AI data sets that is going to give us maybe more personalized treatment for all of our patients, because we now know how much of the way other things bring into the picture. And also to just go along with Malvina said, I think also garbage in, garbage out. We have to start thinking about what's happening within the black box. And I think neurosymbolic is going to be a new way that we actually learn a little bit more how the machines are coming to a conclusion. And in that way, we might probably improve what comes out, accuracy, predictability. So I think neurosymbolic is going to be a new big thing that we're going to be working on very soon.
Wonderful. Well, thank you all for your presentations. Really appreciate it. There's some questions in the Q&A box. If you don't mind answering those for your particular presentations, it'd be wonderful for our listeners to get your answers. And we'll go on to our next section. I'm going to turn over to my co-moderator, Dr. Jenny Lim, who's going to be going over these presentations. Thanks, Jenny.
Thank you so much, Rishi, and welcome to session 3, Retinal Vascular Disease and Artificial Intelligence. We're going to segue now and talk about biomarkers, implementation, and assessments of image analysis. And our first speaker I'm pleased to introduce is Dr. Manuel Amador, who is a Genentech Senior Medical Director for U.S. Medical Affairs with Genentech. And Dr. Amador will be speaking on evaluating emerging retinal biomarkers using AI, clinical relevance and implications. Manuel?
Thank you so much, Jenny, and thank you so much for the organizers for the invitation. Today, I'm very excited to share kind of how we are using deep learning and AI to try to extract more meaningful insights from OCT imaging from our clinical trials, and how this could potentially shape the way that we are assessing disease severity, predicting outcomes, and potentially ultimately kind of improving the patient care. Let's go to the next slide. These are my disclosures. I am a full-time employee of Genentech Roche. Let's go to the next one. So I wanted to bring this case just because I wanted to share how we usually see kind of anatomical markers on patients, especially for this patient that clearly has a very severe disease. This is, of course, the baseline image. If you focus there, you can see that there's extensive intraretinal fluid, some subretinal fluid. There's also some hyperreflective foci, those little small bright dots surrounding the fluid pockets. But here's the issue. We are only seeing that first scan or that 2D slide of the retina, and there's still a vast amount of granular anatomic data that we are still missing and that we are not focusing on. Let's go to the next one. Now take a look at the same patient. So this is the same patient that we saw before, but let's take a look at the patient in 3D. This view is now letting us know beyond what that single plane was allowing us to see. And now we can quantify fluid not only on 2D, but actually on volumes and also the other lesions that are part of the retina, like for example, the HRFs across the entire retina. This gives us a much better or much richer understanding of that disease burden. But now the next question would be is how we turn this 3D information into something actually clinically meaningful. Well, today I want to try to answer that and show how machine learning is allowing us to extract that value and how it may actually help us predict those long-term outcomes or those clinical outcomes. Let's go to the next one. So let's begin with fluid, particularly intraretinal fluid, which tends to be a little bit more persistent in our DME patients. We ask a key question with this analysis, which is, does early intraretinal fluid actually affect long-term vision? Let's go to the next one. So we measure that intraretinal fluid volume using machine learning across 97 OCT scans per patient. Please keep in mind that our clinical trials have thousands of patients. So we look at volumes of patients at the 3 monthly injections, and they correlated those with 2-year outcomes, changes in intraretinal fluid, subretinal fluid, volumes, and mean BCVA and percentage of patients with 15 letters. Let's go to the next one. The novelty, past studies that have shown actually that persistent fluid does lead to worse outcomes. What our novel approach did was trying to measure that, but fluid volumetrically. We use Yosemite and Rhine trial data and analyze patients in a treatment agnostic manner, meaning that the cohort that you will be seeing is the cohort of patients come from all arms, no matter the treatment. Let's go to the next one. We categorize the patients into 3 different groups based on that initial intraretinal fluid resolution after 3 months. Group 1 in red is a 20%, less than 20% reduction. Group 2 in green is an intermediate, basically 20 to 50% reduction. And group 3 is the ones that had the best reduction, more than 50% reduction. Baseline characteristics were very balanced between all these 3 groups. Let's go to the next slide. Patients with early IRF resolution, or group 3, had significantly lower IRF volumes at 2 years. To the right is, let's go to the next slide. Here to the right is an example. We see that that patient, after that initial 3-month resolution, it has sustained resolution after the 2 years. So those examples, those blue patients actually had that improvement of the intraretinal fluid that lasted over the 2 years. Let's go to the next slide. And the same pattern was held true for the total retina thickness. We're not only measuring volumes now, but we're also measuring the total retina thickness. Those early responders had also better retinal anatomy over time. Again, these are all volumetric measurements. Let's go to the next slide. But most importantly, what happened with vision? So a big question that we get is patients with that quick response also had a better vision? Well, most importantly, yes. This supports these patients had significantly better visual acuity after 2 years. Those blue patients that had that quick intraretinal resolution, kind of supporting that hypothesis that early intraretinal fluid resolution is contributing to better long-term visual outcomes. Let's go to the next slide. And we always get the question if after just one injection, we can also see this pattern. Well, the answer is yes. We repeated this analysis using IRF changes after just one injection, and we were also able to predict. So those patients that had that quickest resolution after just one injection also had the better vision gains after the 1-year mark. Let's go to the next slide. So some key takeaways regarding that previous analysis. These are potentially findings that deep learning is giving us the additional granularity to really better understand that disease behavior. And also how that early resolution is potentially helping us guide on treatment decisions. Now, for this analysis, this is a completely different analysis. We're now going to be focusing on hyperreflective foci in DME. This is another potential biomarker of disease severity for diabetic macular edema. Let's go to the next slide. What are hyperreflective foci? Multiple people have hypothesized that there are small reflective structures that may represent activated microglia or infiltrating leukocytes, suggesting that they do mean a specific inflammatory component. Let's go to the next slide. Now, using deep learning, we are able to segment HRFs, and we are talking about lesions that are less than 50 microns. We're going to talk about lesions that are more than 50 microns, but here we are talking specifically about lesions that are less than 50 microns, and we're going to be measuring them up to the week 48 in our trials of Yosemite and Rhine. These are all treatment agnostics, again, meaning that patients were treated with either of the molecules. Let's go to the next slide. Let's go to the next one. And now the clinical correlations. When we stratified by HRFs, volume quartiles, what we saw was that greater baseline of HRFs or those lesions correlated with worse DRSS. This can be potentially expected, but also it was correlated with thicker retinas at baseline. So those patients with higher HRFs had the thicker retinas. And when we looked into the 3-millimeter diameter zone, we saw that patients that had the more HRFs were also associated with lower BCVA at baseline, which again is potentially giving us some sort of prediction towards which patients are coming with a worse disease. Let's go to the next slide. This is also something interesting that we also see some colocalization between those HRF lesions when we look into the on-phase view of the volumetric data and the intraretinal fluid, supporting that there might be this inflammatory component that is kind of surrounding those pockets of fluid and opening some potential new research questions. Let's go to the next slide. And let's go to the next one. So to summarize, again, greater HRF volumes were associated with higher DRSS scores, thicker retinas, and worse vision, making that HRF a potential biomarker for disease severity. Let's go to the next slide. And now let's talk about the lesions that are more than 50 microns, the hard exudates. Let's go to the next one. Hard exudates are considered lipoproteinaceous aggregates deposited primarily in the outer plexiform layer and also are a hallmark of diabetic macular edema. Let's go to the next one. And these are lesions that we measured as more than 50 microns. Let's go to the next slide. Again, we use an automated deep learning-based algorithm. We extracted those hyperreflective foci, not only volumes, but also counts from baseline and up to week 100. The hard exudate volumes were assessed across the 3 millimeter diameter and also the 1 millimeter diameter in the multiple zones of the retina. Let's go now to the findings. Let's go to the next slide. At baseline, we learned that 81% of patients in our clinical trials have hard exudates, so a big percent. And keep in mind that our clinical trials are limiting patients up to HbA1c of 10%. So the real world may even be facing even worse severity for patients and potentially more hard exudates positioned in areas that are potentially more problematic for vision. Patients with hard exudates were also associated with thicker retinas and also with worse DRSS scores. Let's go to the next slide. Another interesting interpretation is that patients with hard exudates had this lower CST and BCVA improvements in the early treatment phase, kind of signaling that these patients are potentially bringing a tougher disease, and maybe we need to start paying more attention to patients that have more hard exudates or that we're able to assess that might have this additional inflammatory component. Let's go to the next slide. And to conclude, I just want to kind of share very quickly that these are just examples of how deep learning and AI are transforming how we are understanding the retinal diseases. By extracting these volumetric data using deep learning algorithms, we're really learning a lot of details about the patient disease that were potentially previously hidden. We're trying to identify new biomarkers of disease severity, and these are just some of the examples that we are currently working on. We are hoping that we can continue predicting some additional visual outcomes from these earlier anatomical responses, and hopefully in the future we can tailor interventions to specifically treat patients that come with more disease severity thanks to these algorithms. And with this, thank you so much. I'll give it back to Jenny.
Thank you so much, Manuel. That was a beautiful talk and showing how you can use AI to really extract these biomarkers. And we look forward to the discussion, so please stay tuned for the panel discussion. It's now my pleasure to introduce Dr. Paul Chen, who is Chair of the Department of Ophthalmology, University of Illinois, the John Penton Professor of Ophthalmology, Director of the Pediatric Retina and ROP programs. And Dr. Chen will be speaking on human-centered design and AI implementation in ophthalmology. Paul?
Great. Thanks so much, Dr. Lim. And also just want to thank Dr. Lang and Dr. Singh for inviting me here. I think this is a terrific meeting, and I appreciate being part of the discussion. Just moving forward to go to the next slide. Great. So here are my disclosures, none of which are related to the talk. And just want to acknowledge the group that I work with. In this specific case, the Institute for Healthcare Delivery Design that I work with at UI Health. And, for the most part, as a pediatric retina surgeon, I've done most of my work in the field of ROP and implementation of technology in that space, specifically in low middle income countries. What I'm going to focus on right now is just a discussion on the implementation process for AI regarding diabetic retinopathy screening. And one of the things that I've thought about a lot throughout my career is just how do we implement technology? And now that we're in this AI space, I think it's very important to think about, okay, what's the best way to get this out to patients? I appreciated Dr. Edelman's discussion around scalability. I think this is very much part of that. So in our health system, similar to many others, we have a significant burden of diabetics. And in the area around UI Health, we have 30 to 40% higher than national rates. What we found early on was that over half of these patients were overdue for diabetic screening. So obviously, like many other systems, we thought about the adoption of the AI technology to implement for these screening programs. Now, as opposed to just buying the equipment and seeing how it worked, we wanted to make sure that we were thoughtful in our implementation process and that we were applying a certain methodology to how we implemented these AI systems. So we partnered with the Institute for Healthcare Delivery Design at UI Health to subscribe to a human-centered design process. And I want to go through that a little bit. So this is human-centered design. It's a problem-solving approach that seeks to understand real-world context. And what it does, it engages all stakeholders in this process as we go through the implementation. We used a UK Design Council's double diamond model, which includes 5 phases, as you can see here: frame, observe, define, build, and evaluate. And I'll go through each of these as we talk through it. So here, framing and observe, again, engaging all the stakeholders in the process, as you can see here in this figure, from the MAs, the leadership within the hospital, leadership within the family medicine practice, and of course, all of us in ophthalmology. And it was very important that everybody was on the same page to understand what the primary goals were. And as I mentioned before, what we did see early on was that referrals to ophthalmology were much lower than 50% in the current state, in the initial state. In terms of defining what success was, this was interesting. And I think this is one of the most interesting things in this journey, which was the definition of success was very different in the very beginning by what family medicine defined it as and what the ophthalmology folks did. So making sure that people in primary care didn't think that the AI system was specifically replacing the overall eye exam, but it was really just a screening method to get patients to ophthalmology and also to make sure that patients were not being seen who didn't have any pathology. So this critical message and making sure everyone is aligned. And then very importantly, evaluating and building the workflows as we implement technology into the primary care space, making sure that their workflows aren't slowed down. You can imagine the number of patients that they see. And if you're adding an additional test, you have to make sure that it's efficient on their end. And very, very importantly, as we all know, you can do the screening, but closing the loop and making sure that these patients get to an ophthalmologist or eye care provider is very, very important in trying to understand what the bottlenecks were in that space. Education was a very important part of this process. We recognized early on that a lot of the patients didn't know why they were getting eye screening, making sure that the staff were understanding and explaining why patients were getting the screening as well. So building out the educational material, building out the checklists, making sure we were closing the loop so that patients understood that they needed to get follow-up. So through that journey with family medicine, we then transitioned into the endocrinology space. What was interesting in the family medicine pilot was that there was a lack of volume to a certain extent for the number of diabetics that were being seen. So we wanted to see if we get any better uptake in endocrinology. This was our timeline, as you can see here, the initial pilot in family medicine, then implementing in endocrinology, and then making sure that we were using the same foundational principles in the endocrinology space. And you can see here some of the issues. And I want to discuss a few of the issues, but also some of the successes that we came about from this program. First, no surprise to everyone here, we had a fair number of false positive and ungradable images. This got better during time with training and then with close attention to educating the MAs on how best to do these images. Second, and I thought this is very important as we all face this. I know Dr. Singh is a healthcare administrator, you deal with these types of challenges a lot, but implementation of the system into the HR. And again, making sure that all the patients who need to be screened are being screened, and we're using the EHR to our advantage. Timely follow-up, and this was one of the major issues that we faced. How do you make sure that the patient gets from the screening to the ophthalmologist or the optometrist for the in-person exam in a timely fashion and when it's warranted? So again, adjusting our workflows to make sure that this was happening. And what was interesting, though, was that without using the AI, we implemented just some simple changes in the EHR scheduling workflows, making sure that the follow-up appointments for the diabetic patients seen in endocrinology were made at the time of checkout at the endocrinology visit. And what this shows us here was that just with that epic change or that EHR workflow change, without the implementation of the AI, while we were waiting for that, showed that it showed improvement of follow-up schedules, but also patients making their appointments to the ophthalmologist. So in summary, I think that we do have to be very thoughtful in our implementation process for artificial intelligence screening programs. Very importantly, it's going to be very specific to the healthcare setting and also making sure that we address the specific needs of the population, the patient population, but also the physicians, the providers, the staff, and everyone involved in the healthcare journey. So thanks very much and look forward to the discussion.
Thank you, Paul. That was wonderful. Thanks for sharing that very thoughtful approach for implementing DR screening using a human-centered design. It's now my great pleasure to introduce Dr. Cecilia Lee, who is the Clarifying Chair in Ophthalmology, Professor of Ophthalmology at the University of Washington, Seattle, and she'll soon be transitioning to Professor of Ophthalmology at Washington University. She is one of the PIs for AI Ready, which is an NIH-funded project for which she and Aaron Lee received $31 million in funding. Dr. Lee will be speaking on AI Ready and Equitable Atlas for Diabetes Insight. Cecilia?
Thank you so much. I really want to thank Dr. Lim and then Dr. Ling and Dr. Singh for this opportunity to present. Really, thank you. So many of the speakers, I don't have any financial disclosure. So there's no question that we have arrived in this big era of big data and machine learning, but many of our speakers mentioned that really the quality of AI models really depend on the training data sets. And so that is really the premise behind this NIH-funded Bridge to AI program. And we recognize that really it's on the data preparation in terms of collecting the data that is readily usable for AI models, machine readable. And also we want to acquire a data set that is diverse and not only diverse in demographics, but also diverse in the disease spectrum. So you are able to cover a large range of from normal to disease progression stage. So that's what we are doing. So we are one of the 4 programs that have been funded to really generate data for future AI modeling. So our data generation project is called AI Ready, or we are focusing on salutogenesis, which is to create a multidimensional, ethically sourced data set in diverse people for studying salutogenesis in type 2 diabetes. It's a little mouthful. And what we are trying to do is that we are trying to really generate a multimodal AI-ready data set that allows us to understand the pathogenesis in type 2 diabetes, understanding many of the risk factors, but then also the reverse. We want to use this data set to understand both the pathogenesis and also potential salutogenesis in terms of making the people healthier or less severe in their disease spectrum. So how do we envision this? So the idea is that if we are able to generate or collect multimodal data, including social determinants of health, cognition, truly multimodal that ranges from not only the eye, but heart, kidney, and genetics data, and a lot of additional data that I'll touch upon later. And then we could use machine learning approaches such as pseudotime manifolds, where by allowing lots of data points that go from normal to disease states, we can actually generate a pseudotime atlas or pseudotime history of somebody becoming from healthy to disease or disease to healthy. And this data set is meant to allow cross-sectional AI model generation that helps with the hypothesis generation and biomarker discovery, but then using applications such as pseudotime manifolds, it is meant to enable some predictive AI modeling that could be helpful in prediction or prognosis of our patients. So we are collecting a total of 4,000 participants from 3 different sites from University of Washington, UCSD, and University of Alabama at Birmingham. I mentioned this diversity being important, so we are equally dividing into men and women and equally balancing the data set into white, Black, Asian, and Hispanic. And then really more importantly, we're actually balancing the disease spectrum. So half of them are non-diabetic, so 25% of them have no diabetes, 25% of them are diet controlled or pre-diabetic, 25% of them medication controlled, and 25% of them insulin controlled. And we go from from head to toe, and really the eye imaging is a minor portion. So they go extensive survey questions such as social determinants of health, depression score, diet survey, and they come to our site, and then we go over all the medications. And we do visual function and various retinal imaging that I'll provide more details later. Physical exam, we do blood and urine tests. We do 12 lead EKG, MoCA, and then we actually collect biospecimens such as buffy coat, plasma, and serum. And then also we extract PBMCs for future iPSC work. And they are discharged with 10-day post-visit continued glucose monitoring, physical activity monitoring, and then also environmental sensor that takes 22 different environmental variables every 15 seconds. So these are some of the examples of how extensive the imaging is. And I hope you'll be very excited to know that every person undergoes 44 different scans per patient. It sounds very extensive, and it is. And we have mentioned a lot of speakers mentioned the standardization, harmonization, how it's really important to have standards. And we definitely recognize that as a bottleneck in our field. And so on purpose, we are obtaining a lot of same imaging through different devices. So let me give an example here. Oh, well, I'll come back to that later. And so let me tell you about the ER2 release data set that was released in December. So released about 1,000 participants data, which is 1/4 of our goal. And this data alone has near 3 million glucose measurements, about 182 million air pollution and light spectrometer readings from that environmental sensor that I mentioned. This is by far the largest OCTA data set that's publicly available because it has about 4 million OCTA images. And by May 1st, at least 500 research organizations worldwide have downloaded as of May. And I am mentioning this so that you can also download it today and really leverage this data set. So this is an image that kind of show how we are doing in terms of split. So you can see the split between healthy, pre-diabetic, and non-insulin insulin. And also there's a good split or diversity between the decades of life. And this is a figure that you can do interactive. It's interactive on our website. So I invite you to kind of look into that. And this is how extensive in terms of the CGM data. By looking at CGM data, you can kind of see the heterogeneity that exists even among the diabetics or among the diabetes group. And you can kind of, you can think about, well, this is very granular and sensitive. How can I use this information to understand better features that correspond to those? This is Nayun Kim, who's in our lab. And then these are some of the images that we go from, cheap to very expensive imaging. And obviously the quality is different. And then also various OCTA and OCT, and also FLEO. And then they're all available for your use. So I mentioned we go from cheap, that is meant to be portable, undilated imaging, to IDON with dilation, and lots of different imaging that you could really develop algorithms that could translate or use the Gen AI models to kind of predict what would be the feature in the other prediction. And also we use FLEO experimental data. So what kind of questions could you answer? So we have labels that are normal, in the diabetes severity, and we have a lot of data on environmental sensors such as pollution data, PM2.5, volatile gas, and we have fitness tracking. And then we have, images such as FLIO. Can you use these imaging to predict, who's diabetic, who's not diabetic? Or can you go between different imaging modality or between different devices? Or are you able to use the random imaging to get better insight on who is, high A1C or CGM data? So those are some of the potential questions that could answer with our data. And you are able to access our AI ready data set. If you type in aiready.org, it will take you directly. And this does not require any DUA. And you can view the documentation with all of the data sets. And please be ready that year 3 data set of near 2,500 people will be released by December of this year. And really take on point is that multimodal data set can reveal novel risk factors and disease trajectories, and diverse balanced data sets are essential for AI models, but collaborations, including people, researchers like you, is going to be key to reach our full potential. I want to thank my members in our lab, and thank you so much.
Thank you so much, Cecilia. That's an amazing project, an amazing body of work that is going to be really a wonderful resource for us to use in the future. And now, it's now my pleasure to introduce Dr. Farhina Ali. Farhina is Assistant Professor of Ophthalmology at New York Medical College, and Dr. Ali will speak on AI and diabetic retinopathy screening. Where are we in 2025? Farhina?
Thank you. Thank you, Jenny, and good morning. Congratulations to the organizers for an excellent meeting, and thanks for this opportunity. We've heard a lot of great work, very much related to what I'll be talking about from Dr. Chan and Dr. Lee. This is a much broader overview, a high-level snapshot of where we are in 2025, what we've learned so far operationalizing AI-enabled diabetic retinopathy screening. So these are my financial disclosures. They'll show up here in a minute. Let me see. Okay, here we go. Skip through that. And so we'll be focusing on the US, but global updates for familiarity. We're no longer in pilot stages. Over 1 million patients are screened annually using systems like IDXDR. There are others, but more on that one later. The first FDA-approved algorithm in 2018, with adoption ranging from US Medicare programs to Indian state screening initiatives. And what we've learned so far is that AI-enabled screening has improved the rates of screening for diabetic retinopathy, as well as rates for follow-up with recommended eye care. We've also seen improved rates across racial, ethnic, and socioeconomically disadvantaged groups. This analysis here shows the estimated number of patients with diabetes progressing to severe vision loss per 100,000 at 5 years, looking at no screening, traditional eye care screening, AI-based screening, showing a potential for preventing vision loss in about 27,000 Americans compared to our historical approaches. Now, through what means, you can see here, FDA approval initially of the IDXDR program paved the way in 2018 with de novo approval. It is now the standard by which any new algorithm seeking approval in the US needs to be compared against. And you can see the sensitivity and specificity as listed here. Really, what's often mentioned in this space is more than moderate DR or referable disease. And we're looking often and talking about sensitivity and specificity as related to that, obviously that being clinically relevant. The iArt system in 2020 and AI Health in 2022, all of these approved and paired with specific cameras, of which the only common to all 3 is the Topcon non-mydriatic NW400. And so the IDXDR system has been available and deployed in a variety of settings. And here you can see from May 2025, a recent meta-analysis of its diagnostic accuracy, pooled sensitivity and specificity, 95% and 91% respectively, with the confidence intervals you can see outlined there. But from an observational standpoint and highlighting some of more of an overview than what has been described so far this morning, but some observational limitations have been noted in routine practice, obviously unique to all settings. specifics are unique to all settings, but we see some common themes. Performance can drop with suboptimal images or patient populations outside the original training distribution. For example, primary care deployment of IDX-DR reports ungradable rates closer to 10 to 20% compared to the under 5% that we're seeing in those pivotal trials. Importantly, sites do grapple with real-world consequences of false positives, over referral burden, and the possibility of missing referable disease in high-risk populations. And so this has led to some workarounds. We've heard some great troubleshooting already this morning, but human-in-the-loop workflows and protocols for local validation, which many of us sound to be involved in. Now, head-to-head validation of these algorithms can be quite difficult, as you can see on the far right. The data sets that the models are evaluated on all have different compositions of patients. Model performance can vary dramatically based on the test data set. That said, here you can see out of the University of Washington, the largest head-to-head validation study, multi-center, over 300,000 retinal images from vets in Washington and Georgia, comparing 7 algorithms for sensitivity and specificity of classifying referable DR versus teleretinal grades. And a wide range of sensitivity was found here. Reassuringly, though, the negative predictive value was relatively high, but most of these performed no better than human graders from this analysis. So algorithms aside, here are some updates and observations on operationalizing an AI framework. You can see, standard sort of model, image acquisition, verification of quality, reporting out results, and of course, reimbursement is all important. So let's look at some successes and challenges. And I think Dr. Chan got into some of these earlier with his program, which has been quite successful there at UIC. But here, first, EHR and health systems integration. So far, we've seen integration with systems like Epic and some other partnerships with IDX-DR do allow for a streamlined workflow in addition to automated results reporting and fast communication with patients. However, as we might imagine, that's not uniformly the case for all EHR systems, and sometimes requiring even manual, in this AI automated sort of realm, manual data transfer, potential for error and inefficiencies as related to that. Billing and reimbursement, of course, very important. You can see the CPT code listed here as is widely used. It has allowed for autonomous AI DR screening covered by CMS. A recent audit from CMS claims data has shown a significant increase in 2021 to 2023 in the use of this. However, this can vary and be more difficult with a diversity of payers and with different AI platforms. There are definitely ongoing costing analyses looking at cost of implementation versus return on investment based on the setting and the scale with AI-enabled DR screening. In terms of image acquisition and quality, some optionality in terms of imaging platforms, with results seen from focusing efforts on training, as has also been highlighted this morning, but the image quality does remain to be the very significant bottleneck in the real world, and inefficiencies and delays as related to that. From a human resource and workflow standpoint, AI can definitely accelerate triage and task shift from specialists to graders. However, we have a long precedent for how we have been doing grading, and culture change can also be difficult. From a quality standpoint, some health systems have employed periodic audits and validation towards meeting local population and disease prevalence, but standardized protocols don't exist at this time uniformly. Now, from a patient communication standpoint, of course, when this works well, it's excellent model for immediate education and referral. However, there can be hiccups within the AI framework requiring a different sort of explainability to our patients than we've historically done in screening settings. Now, separately, the use of AI definitely introduces ethical concerns and other limitations as outlined here. Medical legally, as haven't mentioned yet, for misdiagnosis, if unresolved, who assumes liability for that, especially as more systems move towards autonomy. With respect to false negatives and missed sight-threatening disease, many systems still require human oversight for positive and ungradable cases, but protocols aren't standardized, and that can result in inefficiencies as well. So Dr. Lee highlighted really extraordinary work there looking forward into the future beyond detection, but prediction and prognosis, now being trained to predict not just, the severity, but the future risk of progression to vision-threatening disease, more personalized screening intervals. There's a lot of work going on in this space. Multimodal approaches also on the horizon, not on the horizon, actually being performed by Dr. Lee, towards, really kind of incorporating a variety of different modalities, OCT, in addition to fundus photos, and also the potential for forecasting treatment needs and response to therapies, different therapies, all in combination with direct-to-patient education, potentially. So still a lot of areas to fine-tune, as has already been mentioned, but I'll just say in summary, AI use in DR screening is certainly here, and it's saving vision for patients, especially where access is limited. That being said, performance, equity, and safety do depend on how we deploy, validate, and oversee these tools locally and globally. And I would argue that clinicians do still remain central to this process, not really just as users, but as leaders in validation, advocacy, and ethical deployment. So thank you so much, and I look forward to the discussion.
Thank you so much, Dr. Lee. That was an excellent presentation, really touching upon all the points necessary for DR implementation. It is now my pleasure to introduce Dr. Xincheng Yao, who is the Richard and Loan Hill Endowed Chair in Bioengineering, Professor of Bioengineering and Ophthalmology and Visual Sciences at the University of Illinois at Chicago. Dr. Yao will be speaking on AV differentiation and DR classification. Xincheng?
Oh, thank you, Jenny. Today I will talk about the differential artery and vein analysis in OCTA and how that may affect the DR detection and also treatment prediction. The differential AV analysis can be important because different eye diseases, they may affect, artery and vein system in different way. For this example, in DR, we can see this is the blood vessel caliber, for the vein system. We can see the vein diameter is increased in DR group. But if we pay attention to the artery system, the diameter is decreased compared to control. That's mean compared to normal, subject. This is the blood vessel total OCT. The vein system, we can see significant increase for the blood vessel total OCT in the vein system. But for the artery system, the total OCT is only slightly decreased. For the sickle cell retinopathy, we did not see, significant difference in artery system. I mean, for both total OCT and blood vessel caliber, but we did observe, significant change in the vein system. So that's when vein system can be predominated by the blood vessel totally increase and also the caliber, increase. So this observation, suggests differential AV analysis may improve OCTA sensitivity for eye disease detection. So how to, different the AV system, in the OCTA? In principle, a simple strategy to use the spectral information in color fundus, image to produce the AV map. The AV map can be used to guide, the AV analysis in the OCTA, image. It's also possible to use the OCT reflectance image or even OCTA blood flow, information to different artery and vein in OCTA image. So this is one example to show the cross reflection profile. This feature can be used to separate an artery and vein system based on alpha distribution. It's also interesting to observe the actual profile difference between the artery system and vein system. So the artery system, we would typically, we could, observe both, top wall structure, bottom wall structure clearly. But for the vein, blood vessel, typically we observe, layered structure, from the top to bottom part that reflect the blood flow affect, the reflectance profile in OCT and OCTA. Based on this observation, we try to involve deep learning, for automated AV segmentation in OCT and OCTA image. So for this example, we combine OCT and OCTA image as the, combined input, for AV segmentation in OCTA. We test the different combination, including early fusion, later fusion, strategy. We observed that later fusion showed the best performance to prove it, the accuracy compared to ground truth can be better than 95% accuracy. But if we pay attention to the OCTA only architecture, it's proved similar performance compared to the combined OCT and OCTA input, only slightly, about 1% less compared to the combined OCT OCTA combination. So that suggests the OCTA itself may provide enough information for robust AV segmentation in the OCTA. In addition to the OCT reflectance profile I just mentioned, further analysis indicate the capillary-free zone nearby the individual blood vessel. They can also provide useful information for the deep learning segmentation of artery and vein system in OCTA image. We tested both the 6mm, 3mm, OCTA for the automated segmentation based on deep learning AVNet. So using 3mm OCTA, we were able to segment the AV system up to the microcapillary level nearby the fovea center. In addition to the binary AV segmentation, we also try to involve area segmentation. That's mean to separate the artery and vein vessel covered region. In this way, we can preserve the artery and vein intensity information in OCTA for DR detection or classification. So in the bottom panel, we can see the TPID, that's mean the total, intensity perfusion analysis without AV segmentation. A, that means the artery region. V, that means the vein region. So if we combine the AV analysis together, that's mean to use the relative AV intensity ratio. We can separate the control no DR and mild DR group from the other reliably. Yeah, we also try to check the effect of differential AV analysis on the DR classification. This is one example for binary classification using the whole image before and after, AV segmentation. So the average accuracy, for before AV segmentation is about 79%, and after AV segmentation, the average accuracy will improve to 88%. So we also checked, the regional analysis effect. That means separate image to 3 different regions and calculated the feature from each region separately before we combine all features together, for the classification performance. So before AV analysis, the 3-region analysis, provides the accuracy about 84%. After, the AV analysis, the average accuracy will improve to 93%. So that suggests, AV analysis can further improve their detection sensitivity. We also try to test the effect, about differential AV analysis in OCT prediction of DME treatment. So for this example, we test both the visual acuity improvement and retinal thickness improvement. So before AV analysis, the visual acuity prediction accuracy is about 70%. With the AV analysis, the accuracy would improve to 86%. For the retinal thickness prediction, before AV analysis, the accuracy was 68%. And after, the AV analysis, the performance would improve to about 80%. So that's in more than 10% improvement with the AV, involvement. Okay, in summary, differential analysis can improve the OCTA sensitivity for DR detection, classification, and also for improved DME treatment prediction. We have, deliver a open source toolbox, for OCTA feature analysis. Currently, we are working on the, AV analysis. That means to add, the AV analysis into the open source toolbox. Okay, thank you for your attention.
Thank you so much, Dr. Yao. This is an excellent talk and excellent work. I'd like now to call all my panel members to the panel discussion. Great. So my first question is to Dr. Amador. Manuel, you showed some beautiful images where you can do 3D modeling, you can quantify the amount of hyperreflective foci, you can quantitate the fluid. Would you consider then looking at the data and trying to see if patients who have worse biomarkers for worse disease are the patients who do better with the drug that dries the retina better? So I know it was treatment agnostic. Are you now going to look at the different treatment arms and see, was there a differential response, and did that affect visual acuity?
Jenny, thank you for that question. And yes, we are definitely looking to expand this analysis to further understand better kind of which drug is potentially generating or getting that better drying in the future. This is, of course, in the plan, especially for these tougher patients. Something also interesting that we have found is that there's different groups of patients or populations that do come with worse baseline. This is something that we saw, for example, in the Elevatum trial, where we saw that Hispanics and African Americans do come with more severe biomarkers, HRFs, exudates, and of course, fluid and intraretinal fluid. So we also expect that there might be an impact that could be even better for certain populations if we have certain therapies or target certain therapies towards certain populations. So we're trying to learn a little bit more and expand these learnings, but we're definitely looking forward to look at this, not treatment agnostic, but with the different therapies that are available.
Yeah, we look forward to seeing that data. My next question is for Dr. Lee. Cecilia, the work that you're doing is amazing with AI Ready and particularly with including all of the different groups, with the diversity, which is definitely intentional, right? So that we get huge numbers of patients that are equal across the different racial groups. Looking at the data very early on, has anyone looked to see whether there are new biomarkers that are being discovered? Because we know that certain groups have worse diabetes. Has that been looked at yet, or are you planning on doing that?
No, so we are really excited because our goal was really to generate data for all the other researchers to really do discovery. And then we are now finding some papers that have already been published by other researchers that have downloaded our data and doing their discovery work. So we are very excited. And we are, our investigators are actually not taking advantage of the data, so our PIs are allowed to do research on only publicly available data sets. So we're actually not touching our data set until it's released equally. So if you can think of low-hanging fruit, please do that because everybody can collaborate. So that's our goal, and then we are very excited about that.
And can I just clarify, when these patients get in, it's a huge cohort of patients, are you following them longitudinally as well, or is it a one-time imaging?
It is a one-time imaging, and then we, thought about potentially bringing 10% back in year 4. But I think with the budget constraints, I don't think it will be possible. If there are future opportunities to bring them back, because they are consented to be recontacted for any follow-up or other studies. So we're definitely looking into that.
Yeah, because it'd be really interesting, right, for predictive modeling.
Yes.
And maybe those patients who get into certain studies can be called back by those specific researchers and then go forward. Yeah,
absolutely.
Thank you so much. Farhina, that was a great discussion and talk. You went into a lot of the issues involved that prevent AI from being used effectively in DR screening. Having researched all of that, how are you going to go forward? Let's say you wanted to implement this at your own institution and area. What would be the top 3 things that you would target in order to make it most successful?
Yeah, so I think that for starters, there are limitations, but there have been tremendous successes, and many patients have been screened and disease has been recognized. And so I think we have really good models. The IDXDR setup is a good model. There is cost effectiveness that has been seen there, as well as, we're preventing vision loss. But what I was really impressed by as well are some of the findings that have been seen globally. So for example, Aravind has partnered with Google, and they have done an impressive endeavor in their screening programs that recently was published just last month in JAMA Open, their real world validation. And the rates of validation are really, the rates of success there are really quite high. And I think there's a lot to be learned from that model. We've known over many decades that Aravind has been able to do things at scale in a way that can be very difficult for us to do in the US with all of the disparate systems that we have, different payers, and a variety of complicating factors. But I would encourage folks to kind of look at that work. It was published just last month, and I'll be reviewing it as well. And I think there are some learnings there.
Thank you so much. And Xincheng, you showed us some beautiful work looking at arteries versus veins, and particularly showing how because these veins and arteries are affected differentially, it makes sense to analyze them differently. When you looked at the patients who were treated, did you see changes that differed in the artery, in the caliber or in the venous tortuosity with treatment afterwards? And could that possibly be a biomarker for effectiveness of the treatment?
Yeah, that's possible. We did not check the detail, honestly, but it can be very interesting for us to work together to check the detail. For the treatment study, we simply want to check if the baseline information, which feature can be used to predict the, effectiveness of the treatment. But for more detail, we did not really check it. Yeah, we should check that. Yeah.
Okay, well, maybe we can collaborate on that going forwards.
Sure.
Okay, so thinking now in the whole realm of diabetic retinopathy and how AI can identify biomarkers, how AI can help with screening, how do you think the advent of AI integration into the treatment of diabetic retinopathy will affect our practices in the day-to-day handling of patients? How do you think it's going to impact your workflow and the complexity of the patients that you see? I have my own ideas. I'm curious to hear what you think.
So I think a couple of things show a lot of potential promise and real interest in terms of personalized screening intervals. I think that can be really powerful. I think we see lots of patients with low-grade disease that we have these recommendations from the AAO regarding their frequency of visits. But I think when it's personalized and the patient gets a report that highlights kind of what they have, what we might anticipate in the future, I think that is more meaningful and feels more modern than, okay, you fall into a 6-month follow-up visit. We hope to see you in 6 months. In reality, you're doing fine. You probably don't perceive any trouble. And I think that's where patients sort of get lost. But I think this opportunity for it to be more personalized allows for, I think, what feels like more modern care that the patient can feel kind of more invested in. And I'm very excited about, and Cecilia has talked quite a bit about this, but all the multimodal information, I think we're going to costs are a significant concern, but I think there's a lot of potential with continuous glucose monitoring, a lot of data that can really drive like a really high level of personalized medicine in the future through these modalities that I'm very excited about. And I think makes also for really interesting work for us as clinicians as well.
I thought Dr. Chan gave a beautiful, presentation on what he's doing and then how he's working with the family medicine and then endocrine clinics. And then I think that's, one of the examples how by DR screening and AI integration, now we're able to collaborate with all the other subspecialties. And I think at the end, it's actually going to drive the field of oculomics because everybody, not just ophthalmologists, but everybody else is going to kind of understand better, overall health through the eye. And I think that DR is just the first one to go and then be deployed. So very exciting.
Great, thank you. And I too think that, putting in AI is going to definitely personalize the care, as you pointed out, Verhina. I think it's going to improve the communications and the integration and oculomics, as you pointed out, Cecilia. And I actually think it's actually going to increase the complexity of the type of patients that we see in our offices. I mean, we're already beginning to see the impact of this, where you can screen out the patients who have no retinopathy, so you don't need to see them. And then eventually, when you can get that sweet spot and you can figure out who needs to come back when the patients come back, they're more frequently, I think, going to need treatment. So they're going to be more complex, more labor intensive, more intense work, if you will, in the clinic. And gone will be the days where we're just seeing a patient for DR screening. So I guess we can enjoy it now while we and really push the communications. So thank you all so much. This has been really a wonderful session. Those were wonderful talks, and I learned so much. We'll
Thank
now
you, Jenny.
segue to a word from our sponsors. Obviously, we can't put on a meeting like this without our sponsors, and we will hear now from Apellis as well as Regeneron.
When we started Apellis, it was widely believed that inhibiting complements, especially C3 in the body, was impossible. That sounds like a great challenge.
We wanted to do something that's never been done before. We believe there's a fair chance we could make it work, so it never stopped us.
I can be fearless in the work that I do. I can try new things and not be afraid to fail.
It's about pushing the boundaries and the limits of what we can really achieve together.
We came to a market for PNH where there was only one treatment for the last 14 years. And for geographic atrophy, we've been the first to hit the market for that. Now, we hope to bring new treatments to patients living with rare kidney diseases.
Hearing those patients' stories of how we are making such a huge impact in their lives is just incredible and makes it all worth it.
Community is really important here. We have the space to be vocal about what it is that we believe in and really be pioneers of complement science.
What came through is always the can-do attitude, the work-together attitude of the individuals.
A lot of what we do is complex. We all try to help and solve problems together. We're just scratching the surface on the possibilities of what complement can do, what we can treat, and how we can do it. It's limitless.
In the end, we want to be proud of what we're doing. So if we fail, there will be no regrets, right? Because we did the right thing throughout.
I'd like now to turn it over to Dr. Ted Lang, one of my co-directors for the meeting. Ted?
Hello, everyone. Welcome to Section 4, Artificial Intelligence Applications in Other Disease States. Our first speaker will be Dr. Kavi Thakor from Columbia on the role of expert ophthalmologist eye movements in informing AI systems for enhanced eye disease detection accuracy, interpretability, and efficiency. Kavi.
Thank you so much, Ted, and it's really great to be here to present the work of my team on leveraging the eye movements of ophthalmologists to advance AI systems and to enable better eye disease detection. So as a biomedical engineer and AI data scientist in an ophthalmology department, it's really my charter to develop AI systems that can be readily translated to the ophthalmic clinic. And so to that aim, we have these our lab has these three thrust areas: robustness, interpretability, and portability. So of course, making robust algorithms is a given. They should be generalizable and capable of both detecting disease and also detecting progression, but also be interpretable, so have clinically valid, explainable mechanisms, and then finally low cost and accessible to broad populations and interoperable across data of varying qualities and manufacturers. So today I want to tell you a story specifically of how we enable interpretability by using the eye movements of ophthalmologists. So to give you a taste of what I mean by that, here's an example of eye movement of a glaucoma expert actually looking at a glaucoma OCT report. I think hopefully the video will play. Okay, maybe I'll try it one more time. If not, it's a glaucoma expert looking at a OCT report. And you can, the fixations, oh, there it goes. The fixations are the circles and the saccades are the lines between them. And you can see how quickly they make a decision and also the systematic pattern that's used to make that decision. So it's this that we seek to capture in our AI algorithms. And to explain how we do that, I'll take a quick step back and explain some key themes that are used in transformers, which are the backbones behind large language models like ChatGPT. So these two key principles are positional embeddings and self-attention. So positional embeddings simply refers to the order, for example, in a sentence, the order of words in a sentence, the fact that chasing comes before criminal, for example, in this example. Self-attention is really the heart of transformers, and that emphasizes the strength of association between words in a sentence. So for example, the fact that chasing and criminal would more likely appear together in this example, as opposed to words like chasing and a static object like a tree. So if we take all this to the visual domain, instead of words in a sentence, we break an image into patches. And now here, the positional embeddings refers to the typical spatial layout of an image, so top to bottom, left to right. And the self-attention here would refer to the strength of association between patches towards predicting the class of this image. So for example, to predict this as a cat, the patch that contains the cat's ears and paws would have higher self-attention than the patch that contains this part of the sofa. So now taking all this, how do we actually leverage eye movements of doctors to create augmented vision transformer algorithms? So first, of course, we collect the eye tracking data, for example, using head-mounted eye trackers like this one you see here, or also now screen-based eye trackers, which allow complete freedom of movement, so during the clinical setting. And the patches in blue here that are overlaid on the OCT report show the regions that were fixated. And likewise, we can create the same kind of heat map on high-resolution B scans. And then we leverage these two principles, which I just talked about. So towards positional embeddings, we actually capture the gaze trajectory of the clinicians, so specifically the patches that they look at in the order in which they look. So that really emphasizes efficiency, since we're just looking at a fraction of the image that the doctor actually looks at. And then towards self-attention, we actually align the self-attention matrix of the model. So that is the strength of association of one patch with every other patch that the model comes up with the aggregated eye movement attention of the doctor. And this creates our two models, which we called fixation order informed VIT, or FOI VIT, and ophthalmologist gaze augmented, or OGA VIT. So just to make that a little bit more concrete, here's actually, you can see for the FOI VIT, the patches that the clinician fixated on in context, and we raster stack these in the order in which they were fixated and feed them to a vanilla vision transformer. And what we see excitingly is that while reducing the number of trainable parameters, we're still able to attain comparable or sometimes even slightly better performance than a control model, which does not use gaze, which would use the full image. So we're able to deliver on our efficiency, but also most importantly on our interpretability, because we see that the attention rollout of this FOI VIT actually pays attention to regions that we would teach clinically, like the RNFL probability and GCL probability maps. But I really want to emphasize our OGA VIT, because here we actually add a term to the objective function of the model to align the self-attention of the model with the aggregated expert eye movement heat map. And we see that by doing this over time, the model actually learns to create an attention map that's a fusion. So it's unique, not just the model alone, nor just the aggregated expert eye movement alone, but rather a fusion of the two, which once again shows clinical validity by paying attention to the RNFL and GCL probability maps, but also has quantitatively better performance when we actually enhance the alignment between the AI and the expert compared to a model which does not use eye movements of experts at all. So with all this, let me bring it back home to where I started. How do we actually deploy this in the clinic? So we're actually carrying out a user study with residents. So this is an example of actually one of our experts vetting our first system. Our system shows the regions that the OGAVIT emphasize as important, as you can see highlighted in orange here. And he can toggle back and forth, compare the regions that clinically he would use with the regions the AI suggests. And we actually then assess what is the impact on glaucoma detection accuracy, efficiency, and confidence. And we want to see what impact this has specifically on residents as they're learning systematic viewing behavior. And so far, with our preliminary results from this user study, we've seen that although confidence and accuracy don't change much, the variability, or basically the entropy in the eye movements of residents, actually slightly reduces, showing that so far the AI is helping them to do what they already do, but maybe slightly faster. So for future directions, we hope to take this from glaucoma to AMD, where perhaps by looking at high-resolution B scans, we may be able to see not only improvement in reduction in variability, but also in accuracy and efficiency for residents, just as the eye movements have shown accuracy and efficiency improvements for AI-based eye disease detection. So with that, thank you very much, and really want to thank my lab, and our funding sources and all of you. I look forward to the questions. Oops.
Thank you for an amazing talk. Up next is Leila Vazovic from Duke University, speaking on enhancing AI screening for pediatric retinal diseases with synthetic ultra-wide field fundus image generation. Leila.
Thanks, Ted. Thank you all. First of all, it's a true pleasure to be back here. Just learned tremendously from all of you, but thanks for allowing me to share some of the progress we made in terms of pediatric retinal screening and enhancing AI algorithms for that. So specifically, as Ted has mentioned, I'm going to talk about synthetically ultra-wide field fundus imaging generation to help us improve our algorithms for pediatric screening. Firstly, I want to acknowledge our funding sources. This has been really well funded, really supported by Duke Department of Ophthalmology. And also Optos has provided equipment to help us obtain these images. And then various foundations have supported very much my trainees who have been involved with these projects. So I'm going to provide a little bit of background. As I've shared in the past, we have been introducing ultra-wide field fundus imaging in our pediatrician offices, so our primary care offices, just like we're pioneering work in diabetic retinopathy, as we've heard today, this morning. We very much are using that model to screen pediatric patients in our clinics. And these are undilated images obtained as patients are undergoing well-child exam. We recognize that fundus photography can be easily obtained, and I'll show you some of the data from preliminary studies that we've done. We can very well obtain these images, as I mentioned, without dilation, without really using any expert fundus photographers or our imaging photographers in clinics. These are really nurses in pediatrician office who are helping us obtain these images. And then it's really comfortable for the patients. You'll notice from just the survey from the patients as well as the parents, the ease of collecting these images is quite there. We do take some time to collect about 8 minutes because we're not only doing prime posterior pole photos, but we're also obtaining periphery to get as highest yield images. And then lastly, we have been proactively screening the images and grading them for pathology or as normal. And you'll notice, to our surprise, even in a general pediatrician office, we're finding pathology as frequently as 1 in 10 patients do have changes. And lastly, this is pretty comfortable, and really there's no touch technique to these patients obtaining the images. So if we find that parents as well as patients are quite comfortable with all of it. So clearly over the years now, we are generating more and more data from these pediatrician offices. And we're finding that, yes, we're great at grading ourselves and creating AI algorithm to read this, but clearly there's challenges, especially when you are using ultra-wide field fundus photography. Not only are you having challenges in terms of pathology and widespread diseases that can affect pediatric patients, but also there's a lot of artifacts that come into the play. So we have been developing our algorithms to help us really grade pathology versus no pathology. And with the currently available algorithms, we have been able to get really good accuracy in IOR curves. But, the better, we want to see 90% and higher in all of these. So the question becomes, well, we can continue to obtain images and add to these. How can we improve our algorithms by utilizing potentially artificially or synthetically generated images? So this is really the project in mind that we have currently on task. So we went ahead and graded retrospectively some of the previously obtained images that have lots of pathology, primarily coming to retina clinics, pediatric retina clinics. And you'll notice this is the kind of database we tapped into currently in terms of some normal, but lots of abnormal pathology. Various diseases from exuded retinal detachment to retinoschisis to name it were included in the images obtained. The step one was training classifications of only using real images, and we use real healthy and disease database that I just described. We went, as I showed you, kind of the database of algorithms that we used and went back to test our data. We noticed that dense and net 1-to-1 really performed the most poorly. So we figured we'll pick this one as a training set, and we'll utilize this to improve with our synthetically generated images. So the next step was to use the data we have, the real healthy and disease database, to really generate style again to ADA training. Synthetic images were generated from that. And then we also used our real healthy and disease images to now test the DenseNet 1-to-1 training and utilizing synthetic, but really using the real images for validation nonetheless. And as we kind of went through the cycle, here are the results that I want to show you. As you glean into these images, you'll notice on the left side of the screen, you'll notice the real normal and real abnormal pathology images of these ultra wild field images. You'll notice that those look pretty similar, looking from kind of low magnification, real and abnormal, as well as synthetic images for certain. And then when we went further to utilize these synthetic images as we generated, we wanted to see if we used 50 versus 100 versus 200 versus 400, how would that improve our performance of screening tool for algorithm generation? And you'll notice that improvements was seen only after 100 images for certain in terms of error core curve noticed, and really the difference between those was significant. Again, just as 100 images, but most certainly 200 and 400 work just as well. So to summarize in our discussion here, we do believe that generation of these synthetic images can help us really improve our algorithms and data generation, especially in these, diabetic retinopathy, for example, is a wide field, and we more and more have images generating that field. But in pediatric diseases, we often are really limited by data sets, more so in any other age group. So I feel that this really would help us improve on our algorithm generation. And then limitation always become the number of images that are there. But also we are currently using images from a single institution, a larger academic center, but clearly done in one clinic. And we know this Stalging 2 ADA is a really intense data training type of platform that clearly can help us generate, but it's time consuming. So in conclusion, I hope I shared with you some of the work we've done to generate synthetically ultra-wide field optos images to help us really with screening tools for pediatric retinal diseases in general clinics. We hope to utilize this as we move forward in generating our AI algorithms for screening these patients as they're continue to be incorporated in our research studies. Thank you so much for your time. And clearly, it's always a team that that's contributed to all of these studies. And I want to really thank my research team, but particularly our pediatrician office, for helping us really recruit all these patients and collect this data prospectively. Thank you so much for your time.
Wonderful talk, Leila. I think synthetic data is definitely a hot area these days in training AI models. Next up is Sally Baxter from the Shiley Eye Institute in San Diego, and she'll be speaking on using generative AI to manage physicians' EHR inboxes. Sally.
Thanks, Ted, and a pleasure to be here today. Let me advance the slide here. So these are my disclosures, which are relevant to this talk. I think if you haven't heard about large language models, you've probably been living under a rock. I think everyone who's at this summit interested in AI has heard about large language models. And this really, I think, in the last couple of years represents a huge step forward and advance for AI in general. Now, just a brief introduction, large language models are a type of generative AI that are trained on a corpus of data to generate novel human-like content from a prompt. So it's really not so much, categories and classification, but really generating human language. And because of this, it's had so many applications in healthcare. But one that I'm going to focus on, which may be a little bit different from some of the other talks here that are really focused on ophthalmology specific applications. This is maybe more of a general medical application, which is, the dreaded inbox. So at UC San Diego, we were very lucky to be one of the first places to pilot using GPT to draft replies to patient messages in electronic health records. This was a real source of burden and burnout for us. We actually had a large number of primary care doctors leave the institution because of the burnout from electronic health records. So it was a high priority area for our institution to address. And we were, one of the first places to be able to put this into live operational use. It was featured in the Wall Street Journal, and I'll talk a little bit about our papers that ended up, describing our point of care trial. But essentially the background was that it was a source of burnout, and the thought was that we could use these large language models to help draft replies to in-basket messages and just, try to speed up that process, make it more efficient for, physicians to respond to the wealth of messages and the constant stream of communications that they have to manage. And so, we did an initial investigation around, what message characteristics were associated with burnout. And that was a few years back, a work that I led with our informatics team here at UC San Diego. And we were trying to then, from there, take our sample of in-basket messages that we had extracted from the system and look at what the actual physician responses were in the EHR versus what ChatGPT generated responses would look like. And the idea here was to just do an initial exploration, see if we had any issues with the ChatGPT responses and be able to tailor the prompts and the design of our point of care trial down the line. And so the initial exploratory analysis, again, this was not point of care yet. This was outside our operational system. We put in real messages, got the responses and compared them the actual responses. And we saw a couple of issues. One was that the LLMs would refer to themselves or refer to healthcare providers sort of externally instead of acting as the healthcare provider directly. It would say, it's important to discuss with your healthcare provider. And it will always say, discuss with your healthcare provider, kind of this third person type of stance. Another issue was that it would self-reference being an AI model. So here's one, and you can see actually, surprisingly, there are a number of very negative messages that came through the in-basket. I think that was one of the interesting insights from this as well. But that the LLM generated response would say, as an AI, I don't have personal feelings or beliefs. I don't have the ability to experience emotions or go to heaven or hell. And so that was also an issue, like referring to itself being an AI. And finally, one of the biggest issues especially when we had negative messages coming in through the EHR, you can see this long tirade from this patient here, was that sometimes the LLM would actually escalate the situation and say, request a meeting with the physician supervisor, contact the state medical board or professional society, and things along those lines, which we really did not want the LLMs to be doing that and escalating situations. So I think for the trial, we built all of these into our prompts. And so that was, not referring to a healthcare provider in the third person. Really, we want the LLM to act as the healthcare provider and draft the reply, sort of in a first person stance. exclude self-referencing as an AI model, avoid dispensing medical advice. This is for, sort of medical legal reasons. Really be concise. I think everybody's experience with ChatGPT is that its default state is to be quite long-winded. And another thing that we wanted to put in our prompts was to really make it more tailored to each patient. So we actually did have smart phrases and epic tools and smart sets to bring in the patient's current medications and problem list. So with that, we then endeavored on a point of care trial. And, this was actually the first point of care randomized trial of generative AI LLM tools in operational use. So like in actual real clinical settings as opposed to in a research environment. And we looked at time spent on responding to messages, usability, and the physician experience, kind of a mixed methods approach, looking at the quantitative time metrics as well as qualitative feedback from the physicians. And this initial study was, to look at whether we had any issues and inform future use. And we started with a relatively small group of about 27 in the immediate activation. Then we had a group with delayed activation and a larger group with no activation. And that was, using the LLM. So the LLM would generate a draft reply, and the physician had the ability to start with a draft or start with a blank reply. We also had feedback mechanisms to help us refine the future design. And one thing that we saw was that the LLM often required editing. So the red box here kind of highlights where the physician reviewed the draft reply and saw that, the LLM hadn't recognized this person had an appointment coming up. And so she had to add some content there. And the main takeaway was that this was not the silver bullet that we had hoped, right? So we thought that having the draft replies would really speed up things and make it easier for physicians. But actually, it was associated with a significant increase in read time, no change in reply time, and significantly longer replies. And this was based on audit log data that we were able to analyze to take a look at that. The survey results from the group around the usefulness of the AI generated replies, as you can see from the figures, was pretty spread out. It wasn't like, oh, everyone thought that this was so great. And if you dig into the feedback, people, there were comments around, it kind of sounds robotic, it doesn't have my voice, it's not personalized to the patient, it requires a lot of editing. So there was some mixed feedback, and I think a lot of good insights about how we might improve this in the future. And so I think that is something to keep in mind, that a lot of these AI tools, there's a lot of hype, there's a lot of excitement, but there's also a lot of realities about things that we have to address. And for this application in particular, about having greater personalization and an ability to search for other parts of the chart, looking at visits, looking at other information that's available. And it was really funny because we actually had some physicians say the patient's going to know it's not me because it sounds too nice. So this idea of tone and personalization and keeping, your voice maintained, I think, is another thing that we didn't quite expect. So we did write this up, and it's available in JAMA Network Open if you'd like to see more details about it. And I think our next steps have been to expanding this to discharge summary generation, progress notes, and a lot of the nursing communication tools as well. A lot of challenges, and I know we're short on time, but I think that, again, it's not sort of this easy solution that has no issues. It definitely still has a lot of issues around security and bias, prompt engineering, and actually cost is a big one too, because every message that we generate comes with some cost to the health system. So we're looking into all of that as we expand in the future. A large part of this was funded by the AMA, American Medical Association Practice Transformation Initiative, and just want to say thanks to the informatics leadership at UCSD as well, who made this all possible. Thanks, everyone.
Thank you, Sally, for that wonderful talk. Next up is Samantha Scott, who's the founder and CEO of JuneBrain, based in Baltimore. And she will be discussing Beyond the Retina, expanding neurology screening with AI in eye care. Sam.
All right, thank you, Ted. And hi, everyone. Thank you for having me here. I'm excited to share a bit about, from a very high level, Again, introducing neurology screening into eye care clinics and how AI can facilitate this collaboration. Let me see. So eye care settings are currently underutilized for systemic disease detection. And today I'll really focus again on neurological disease. So eye care clinics, as well as primary care clinics, they really serve as one of the most reliable, most often approached clinical settings where patients actually interface with clinicians on a regular basis. So there are 73 to 100 million eye doctor visits per year in the US. And this is compared to around 11 million annual visits to the neurology clinic. And at the same time, there's almost 100 million people estimated to be living with neurological disease in the US. So there's a very clear discrepancy between the patient population and the amount of resources available to monitor their disease. So it provides an opportunity for early neurology screening in eye care clinics. This is primarily because the retina is an extension of the diencephalon. It's literally an extension of the brain, and it's often referred to as the neural part of the eye. And changes in the retina often reflect disease processes in the central nervous system. One of the primary examples is with multiple sclerosis. So a leading 4-year study showed that OCT reflects brain atrophy in MS patients. Specifically, this included rates of RNFL and GCIPL thinning, reflecting MS-related optic nerve neurodegeneration, correlations with changes in the patient's vision, disability, and even brain atrophy is measured by MRI. OCT has also been found to predict future disability accumulation, conversion of clinically isolated syndrome to MS, and even disease activity in people with radiologically isolated syndrome. So the case where you have brain lesions that are characteristic of MS, but the patients are not exhibiting symptoms associated with MS. In addition, what we found is that the retina can also be used to track responses to treatment. Ibudilast is a medication that's currently being investigated as a potential treatment for progressive MS. It's shown to slow the progression of brain atrophy by reducing neuroinflammation and providing a level of neuroprotection. And most recently, the SPRINT MS trial found that ibudilast reduced composite GCIPL atrophy in patients with primary progressive MS. That's compared to a placebo group. So given this huge body of research, OCT was recently formally added to the McDonald diagnostic criteria for MS. And again, this is because MS-related damage can occur simultaneously in both the optic nerves and brain tissue. One of the main criteria for diagnosis is dissemination in space, or the presence of neurological damage in multiple locations across the central nervous system. So the optic nerve has now been added as a fifth topographic marker to help prove DIS for MS. But use of the retina as a biomarker also extends to other diseases, including Alzheimer's, where early signs of dementia have been shown to manifest in the retina. ERG and OCT have found functional and structural changes in the retina that suggest it can be used as a tool for early detection of Alzheimer's disease, and specifically in cognitively normal individuals with amyloid beta deposition. They found decreased macular and RNFL thickness and increased implicit time in those individuals compared to the group without amyloid beta deposition. So it really serves as a preclinical screening measure. And then finally, with Parkinson's disease, a retrospective study used AI to identify changes in the retina associated with Parkinson's up to 7 years before clinical presentation. This included a reduced thickness of the INL, GCIPL, RNFL, in individuals who went on to develop Parkinson's disease. And this was reproducible across two major independent data sets. So while the retina has become a clear neurodiagnostic marker for neurology, they lack access to OCT. That's because they lack the clinical space, often for conventional OCT machines. They lack trained operators. Often they can't accommodate the high capital cost of the equipment, and they're still learning how to integrate retinal biomarkers into neurology practice. So there's an opportunity for collaboration with eye care providers for early detection. And AI can help support this collaboration. Many of the advantages include detection of neurodegenerative diseases in their preclinical stages. So using automated segmentation, for example, to track changes in the thickness of relevant layers, as well as changes in vasculature in the retina. It can also be used to integrate AI with other modalities like MRI results, and even enhance endpoint sensitivity for neuroprotective and remyelinating drug trials. And of course, it can be used to help with longitudinal tracking of disease progression and a response to treatment. However, there are, of course, challenges in making sure that such a collaboration would be efficient and meaningful to both sides. One, eye care providers may be reluctant to refer patients based simply on AI results, especially when they're not presenting with any neurological symptoms. There's also a lack of confirmatory tools like MRI on site, and there's the potential for AI tools to disrupt clinical workflow. One of the most critical instances, and this has been brought up many times during the summit, is generalizability, ensuring that these algorithms can work across a diverse group of patients. And finally, eye care and neurology interoperability is very limited right now. EHR systems do not talk to each other. There have to be clear systems in place to make it easy to move results from the eye care setting and translate them in a way that's clinically meaningful for neurology. So there's many startups who are developing tools to remove these barriers to access. My company, for example, JuneBrain, our team has developed a wearable OCT device to make OCT imaging more accessible for low mobility patients in the eye care setting, and it's backed by an automated segmentation algorithm. But we are one of many startups advancing the field of oculomics, so essentially using AI algorithms that use fundus or OCT images, for example, to provide insights into systemic health. So on a final note, I wanted to really emphasize the real-world impact that could come from a successful collaboration between neurology and eye care practices. 1 in 3 adults will experience a neurological disorder in their lifetime, but there's currently only 14,000 neurologists in the US to serve this enormous patient population. So AI, especially using OCT, can extend access to rural and underserved populations where neuroimaging is limited. So thank you very much.
Wonderful talk, Sam. Next up is Andrew Lottery, who will be speaking on specialist vision language models for clinical ophthalmology. Andrew.
Thank you very much, Ted, and thank you to Jennifer for the kind invite to this wonderful meeting. And I'd like to acknowledge my co-workers, and particularly Robbie Holland, who's a computer scientist who led this work as part of the Pinnacle Consortium, which is a project funded by the Wellcome Trust. Next slide, please. Thanks. These are my conflicts of interest, none of which related to this, relevant to this presentation. And next slide, please. So the take-home message is that we demonstrate that OpenAI's ChatGPT 4.0 model, in addition to 2 foundation VLMs, or vision language models, is designated for medical use. Designed for medical use, are markedly underperformed compared to practicing ophthalmologists on specialist tasks crucial to the care of patients with AMD. And by pre-training a VLM with a specified curriculum, we have created Retinal VLM. And Retinal VLM can write reports that significantly outperform leading foundation medical VLMs and ChatGPT in disease staging and patient referral, and approach the diagnostic performance of ophthalmologists. And these results reinforce that our curriculum-based approach provides a blueprint towards specializing foundation medical VLMs for real-world clinical tasks. So you can submit an OCT image to ChatGPT and ask it to comment on the features in this OCT image, and it will give you results like this. But the training data of foundation vision large language models such as ChatGPT has been collected agnostically towards their downstream applications. And it's unclear whether their general performance translates to clinical utility in specialist medical domains. So here's some images submitted to ChatGPT, and it identifies some of the key biomarkers in these images, but misses others, such as subretinal hyperreflective material or subretinal fluid, and sometimes hallucinates, for example, saying a healthy image has early or intermediate AMD. So our approach is to specialize the training of the vision language model. As I said, this work represents Retinal VLM, a specialized generative VLM for ophthalmology. And so the first stage used a dedicated training curriculum consisting of over 41,000 OCT images taken from my clinics in Southampton, and over 479,000 corresponding question-answer pairs created with independent large language models. And these cover a predefined set of capabilities required for disease staging, patient referral, and biomarker analysis in AMD. And in the second stage, we tasked 2 ophthalmologists to create comprehensive textual reports for a subset of 330 OCT images, detailing comprehensive biomarkers and retinal anatomy in their reports. And then Retinal VLM was retrained using an independent LLM to automatically generate further comprehensive question-answer reports, averaging 216 question-answer reports per image. So just to go through that again, there's initial training in over 41,000 images, which creates over 400,000 visual question-answer pairs. Retinal specialists write comprehensive textual reports in a subset of 330 OCT images. And then large language models are retrained in these detailed clinical reports. In particular, it refines biomarkers, disease staging, and referral reasoning using over 71,000 visual question-answer pairs. And the results are most accurate visual language model Retinal VLM specialists. So in terms of results, Retinal VLM outperforms foundation vision language models in providing accurate detailed textual responses related to disease staging, referral, or biomarker identification in AMD. And it nears the performance of ophthalmologists in interpretation of OCT scans. We also looked at patient referral, and its performance surpasses opticians in AMD patient screening and referral in terms of a significantly lower false positive rate, and it approaches the accuracy of junior ophthalmologists and outperforms the other large language models that we looked at. So how could this be useful? Well, it provides versatile textual interaction for image-based clinical tasks. So you can interrogate it's a sort of a chatbot that can tell you what biomarkers are present, what features, what abnormalities are in the image, and whether a patient should be referred based on the OCT image. So it's useful for potentially for disease staging, for patient triage and referral, and for biomarker verification. So we had 2 senior ophthalmologists, myself and Dr. Shobha Sivaprasad, review in a blinded way reports from ChatGPT, Retinal VLM specialists, and junior ophthalmologists and assessed the reports for correctness, completeness, and conciseness in a blinded way. And we felt that junior ophthalmologists were the most accurate, but retinal VLM specialist was second and significantly ahead of other large language models such as ChatGPT. It's also useful for biomarker detection, and it can provide localization of biomarkers via saliency maps, and so provide plausibility to its reports. So our conclusions are, well, firstly, our work has limitations that need further work. This is only trained in 2D OCT scans, not a full volumetric OCT scan. It's only trained in one image and not a temporal sequence, which we often have in clinical practice. And it's not trained in other retinal pathology, such as diabetic retinopathy. However, it demonstrates that a curriculum-based approach is more accurate in solving real-world clinical problems than training on broad, unstructured data sets. And that's really the point of this work. So our proposed curriculum-based approach provides a blueprint for specializing vision language models that generate true value in healthcare. This work's under revision at MPJ Digital Medicine. And just that take-home message again, existing foundation VLMs are not able to solve real-world ophthalmological tasks. Dedicated training curricula consisting of domain-specific visual question answers can specialize VLMs in image-based clinical decision-making. And the work's also available as a preprint as well. Thank you very much.
Wow, that's really interesting work you're doing, Andrew. Next up is Durga Borkar from Duke, who will be speaking about leveraging natural language processing to identify patients with uveitic macular edema in the iris registry. Durga.
Great. Thank you so much for the opportunity to speak on this topic. This is something that I worked on in collaboration with both the Bausch & Lomb HEOR team and also the team at Verana Health, which is the technology partner for the iris registry. These are my financial disclosures. So when we think about how we've really done clinical outcome studies thus far, we've identified ophthalmic diseases largely based on ICD codes. And a lot of these codes are, really intentionally built for billing purposes, not necessarily research. So when we think about the history of this and validating different disease states that we may be able to study, it's very varied. So the initial study that was done on this was actually done with ICD code 9 codes. So this is a study from Josh Stein where it was a collaboration between Duke and the Kellogg Eye Centers. They looked at a variety of healthcare providers, comprehensive ophthalmologists, subspecialists, and they looked at how they could use ICD-9 codes alone to identify diseases like cataract, glaucoma suspect, primary open-angle glaucoma, proliferative diabetic retinopathy, and dry AMD, and overall found that the positive predictive value was about 97%. So that's interesting because even before we converted to ICD-10, we were very good at identifying common diseases. So in contrast, the study was done using some of the work that I did with Nisha Acharya when I was at the Proctor Foundation, looking at uveitis codes. So looking at ICD-9 codes, and we compiled these code lists from basically prior ocular inflammatory disease studies that had been done, we found about 900 cases. And when we did individual chart review, only 224 of those cases were confirmed. So overall, really the positive predictive value of all the codes together was 61%, but the range was from 0 to 100%, and only 11 codes out of over 50 that we looked at had a PPV higher than 80%. This study was then replicated when I was at Mass Eye and Ear with Matt McKay. We looked at this with ICD-10 codes, and actually we found that for uveitis, using ICD codes alone for EHR-based outcome studies didn't really have a good positive predictive value. So what we've seen is that, validation studies are really becoming commonplace for each disease area studied in ophthalmology and in medicine. And across specialties, we see that the results show that common diseases can be well studied with structured data alone, particularly with the transition to ICD-10 codes. I did a study with Cindy Kai here at Duke where we looked at what happened as we transitioned from ICD-9 to ICD-10 coding to identify diabetic retinopathy. And what we found was that there was a significant increase in both the positive predictive value, sensitivity, and specificity of these codes as we transition to more specific coding. And Brian Vanderbeek has done some work at Penn to show that using ancillary coding, like understanding if vitrectomy was done or PRP, can help increase the reliability of these codes even more. The problem becomes, though, when we try to study rare diseases like uveitis or inherited retinal degenerations, where we really can't identify these diseases just based on structured data alone. So our objective in this project was really to develop an NLP algorithm to identify patients with active uveitic macular edema from EHR data in the IRIS registry. And part of why that was important is as we're coming up with more therapeutic agents for specific disease states and specific complications of disease states like macular edema, it becomes increasingly important to be able to accurately find these patients in large EHR registries. So just thinking big picture about what we did. So initially, 2 fellowship-trained retina specialists identified a combination of ICD-10 codes for non-infectious uveitis and macular edema. There isn't actually a code specifically for uveitic macular edema. So that we were looking at basically the overlap of having a uveitis code and then also a code for macular edema. And then we also developed a list of uveitic macular edema keywords that might be found in clinical notes. An algorithm was then developed and validated to identify patients with an active UME diagnosis at any given encounter in the IRIS registry based on the unstructured data definition using a SPACY phrase matcher. And SPACY is basically an open source library with NLP algorithms that are in the Python language as well as others. And then we applied this algorithm to identify patients with active UME in the IRIS registry. And we compared the number of patients that were identified in the IRIS registry using unstructured data to the number identified just based on ICD codes alone. So initially, we had thought that we would just start with patients that had ICD-10 codes for uveitic macular edema, but we actually found, or for uveitis and macular edema, we actually found that that missed quite a few patients. So then we started, our kind of top of the funnel was basically all patients in the IRIS registry. And we did some pre-processing and surfacing notes based on these UME keywords that we had developed, used the SPACY phrase matcher module, and then also tried to determine UME status at the encounter level, because one thing that was important was that although this could be a chronic or recurrent problem, it could also be something that was acute and resolved. And for many studies that we do, it's important to find patients with active disease. And so that's how we generated our final output. So overall, over 231,000 patients with uveitic macular edema keywords in their clinical notes were found when we looked from basically 2016 to 2023. And for this study, 500 randomly selected patients with these keywords in their clinical records were labeled by clinical experts. So we basically labeled patients as having, UME or not, and then active or no or unknown, whether it's active UME status. And we randomly sampled patients with stratification across the EHR system. So there's over 28 different EHR systems in IRIS, and the way things are documented can be different. The notes were then truncated and concatenated at the patient encounter level for labeling purposes, and at least two, either myself or another retina specialist, Ted Lang, looked at these notes, as well as we have clinical abstractors and labelers. And the goal was to really achieve a good inter-rater reliability. So after we had labeled the data set, it was split 7-3 for algorithm development. So 350 patients were in the development set and 150 in the validation set. And we looked at the performance in terms of accuracy, sensitivity, and specificity. And then this final algorithm was applied to all patients in the IRIS registry. So overall, this algorithm actually did very well when we looked at how it performed in the validation set. The overall accuracy, sensitivity, and specificity were 0.83, 0.95, and 0.73 respectively. And when we looked at the F1 scores for confirmed active UME and either no active UME or unknown, it was 0.81 and 0.83, which, we were hoping for something over 0.7 to 0.75. So overall, this performed fairly well. We then looked at the number of patients that we were able to identify. So there were 231,000 patients with UME keywords and clinical notes. And from this, we identified 129,000 patients that had active UME at any given encounter in the IRIS registry. But I think what was most interesting is we then compared this to what would happen if you just used ICD-10 codes to identify uveitic macular edema patients. And you can see that there were over 129,000 active UME patients identified by the algorithm and only 40,000 identified by the ICD-10 codes. And so what was interesting here is that, there's about a 25,000 patient overlap. So just to wrap up, UME patients are really difficult to identify in real-world clinical research settings using structured data alone, and this algorithm demonstrated pretty good performance in identifying patients with active UME, and it actually was able to identify 3 times more patients with active UME compared to using ICD-10 codes alone. So solutions like this might be necessary to conduct outcome studies for UME and other rare diseases using EHR data. Thank you.
Thank you for that wonderful talk, Durga. Our last speaker in this section is Dr. Stephanie Campbell from OCO Health, who will be speaking about time series data from the patient's smartphone.
Thank you very much indeed. I really appreciate the invitation and the opportunity to share with you. This ongoing research today. So as Ted said, I'm Stephanie Campbell, and I'm a vision scientist by background, and I've been working on home monitoring. We've been developing an AI for home monitoring data from vision from a smartphone, and I'm just figuring out how to move my slides on, but I think, oh, there we go. Yeah, great. So my disclosure, I'm a founder of OCO Health and therefore a shareholder as well. And why have I decided to focus on the smartphone? Well, essentially because everyone has got one in their pocket or probably on their desk right now. And really because this allows us to get information on a really regular basis. And I'm conscious that most patients, their vision deteriorates not just before they come to clinic, but at some point between a clinic interval. And what have they got in their home at that moment? They've actually got a smartphone. So therefore, I'm interested in what data can we get from that smartphone on a really regular basis, but also because it's so engaging in smartphone, we can also be giving feedback back to the patient as well. So that data from the smartphone that really indicates and should prompt a clinic visit is where this piece of research is going. And I believe fundamentally that patients are one of the most underutilized resources that we have in terms of ophthalmology data at the moment. So this is about harnessing the power of the patients themselves, but also it's about gathering high quality longitudinal data. And that's very much possible through the smartphone, but also very much that the patient can potentially, through the feedback that we give them, into their smartphone, potentially become an expert in their own vision data by themselves. And I'd love every patient of ours to become an expert in their own vision. And so far, and for really good reasons, data, and AI has really concentrated a lot on structural data. Obviously, this session has got a wide variety of AIs and a wide variety of types of data used, but a lot of it, when we're trying to predict and monitor disease, we look at structural data. However, if we can add function vision data to that and also patient reported data, such that you see on the right-hand side of that slide, if we can standardize these things, then potentially we can automate and support lots of patients at scale, especially if we can connect that with the smartphone. And so my work for the last about 10 years really has been designing ways of measuring vision to a very high standard on a smartphone. So what I've been doing is creating these puzzle games in order to measure vision. And so on the left-hand side, for example, those of you familiar with pediatric techniques will recognize that those are vanishing optotypes on the left-hand side. And I'll not go into detail on each of the individual ones. But essentially, what I'm trying to do is measure vision across various different aspects. And you know yourself, if you've got patients, you can line up 10 different patients who've each got a, say, 20/40 vision, and yet they'll see the world very differently. And that's because if we reduce vision down to a simple measure of visual acuity, then we lose an awful lot of the nuance. So these games are about putting that nuance back in and gathering more data in the first instance and then simplifying that back down. And because patients play these little puzzle games on a weekly basis and up to 3 times a week, that's what creates what we call time series data. So this is a type of data that's collected in time series. And for example, you'll appreciate that if a patient, say with patchy vision field loss because of diabetic eye disease, sometimes when they read the eye chart, they'll miss letters further up, but actually with enough time and with enough effort, they will be able to get letters further down the chart. And that's the type of nuance that we'll lose in a visual acuity measurement, but we are able to get on a phone measurement. So this is the type of data that's going into time series analysis. And what we're doing then is tagging that to clinical, ultimately it will be clinical decisions, but right now we're tagging to OCT features. So I must extend a thanks here to Nottingham Hospital and Oxford Hospital in the UK, where we've been following 400 patients and their smartphone data and their OCT scans. And what we're looking for in OCT changes, there's about 50 different features. I've just put a few on here, but we're looking for a change in these features since their last visit. And we're mapping the vision data from the smartphone to a change in features, in OCT features. And I'll show you, this is non-AI data. This is just data that comes in from the smartphone. This is distortion data. And so the ring of spots that you saw on a previous slide on the right-hand side, we're looking at the response time to that. So this is a data set, a very simplified data set on distortion for somebody who had bilateral dry macular degeneration and one of those eyes went wet. And you can see that in the blue trend upwards. And it was a long time before they were treated, and their eye didn't respond very well to treatment. This was actually a COVID patient. But if we look here on the next slide, you can see that this patient was identified quickly as having a vision change, and then the vision improved, the distortion improved very quickly in response to treatment. So essentially, we're trying to, instead of eyeballing this, we're trying to do this with AI. And so what we're doing there is we're looking at the temporal patterns, we're looking at the trends, and we're looking at the variability, and we're trying to reduce out that variability. And that's a really important part of the AI. So the smoothing features, for example, using exponential weighted functions and cosine weighted functions in the first instance. And what we're also doing is looking at gradients. So we're exploring relationships using the data in an intelligent way. For example, what is the change in response time to the tapping on the screen versus a change in the visual acuity? And the next step with the algorithm is very much reducing the dimensions, reduction in the dimensions. So we create a lot of dimensions of data, but we need to reduce those down so that we're ultimately creating one dimension out of all of this data. If you look at that middle graphic there. So what we want is one representation for each patient. And then essentially what we want is a binary true false output. So should this patient, when they've finished that gameplay for that day, should that patient go forward for an OCT, or does the previous window of data look like everything is stable? So essentially that's what we're doing here. So to develop an algorithm, we're very much still in the refinement process. And what we're doing is training and testing splits. That's been done on the data so that we generalize the algorithm to new and unseen data that's outside of the distribution it's been trained on. And then we're also cutting out specific patients so that we can be tested on unseen cases as well. So far, we've got an area under the curve of 0.67. And that's on N equals 400 patients, but we're going to keep going using automated segmentation, also looking at clinical decisions as well, not just on OCT features, which is a real limitation of this work at the moment. And so that's the process we're in. But ultimately, if we can get this to work, it will mean that we don't have to eyeball the graphs individually, that we're able to have an algorithm running in the background, detecting any changes earlier, and moving on from there to try and feed back to the patient to create a good educated patient base. So I just want to thank everyone that's worked on this, in particular my machine learning engineer, Dr. Will Leaney, and also the clinical teams in the NHS, Nottingham, Oxford, and the Macular Society, our patient charity, and the government funder, Innovate UK, for financing this work. So thank you.
Wonderful talk. Can we have all the speakers turn on their videos and microphones, and we'll proceed to our panel discussion for about 5 minutes now. And anyone in the audience, please also ask questions in the Q&A. But my first question is for Layla. I think I brought up the synthetic images before, I think is a really kind of interesting concept, but I think a lot of folks don't really have a real grasp of what that is. And, some very basic questions like, how do you know that when you create a synthetic image, that each image is actually unique? And also, like, how much does it actually cost to make one? Like, I mean, it must take some computing power and some resources to generate these images. Can you kind of just go over that a little bit, please?
But certainly. No, those are excellent questions. Thanks, Ted. First of all, thanks for the opportunity to be here, and what amazing talks for certain. To be specific regarding the question for me, yes, we do not know if it's exact replica. Like, definitely, like on our visualization, looks different than what we inputted in there. But yes, they are synthetically generated images. But improving the algorithm itself and just seeing how well it performed on the real images, we do think that it does help with the training overall. And then to answer the question of cost, it really comes down to really buying the equipment, the powerful computers to run it. And of course, the more data you're running behind the scenes, the more costly equipment is. We're starting with, $2,000 to $5,000 investment in the computers currently, but I'm sure the future will be much higher computing powers for all of that. So to answer your question, low cost currently, but I'm sure the cost will increase in the future, and hopefully with cheaper technology overall being in the future as well, that may not be as costly. So.
Well, yeah, I think, generating synthetic images is certainly a great way of getting around finding real data for rare diseases and other conditions where the data isn't quite as accessible. So I think you're definitely heading in the right direction there. Kavi, I thought your talk was really interesting, looking at how experts are using their eyeballs to look at images to learn from how humans with domain expertise are training themselves, and that could train an AI as well. What other areas are you looking at for capturing this data, and how do you think you can actually deploy the algorithms you're creating in the real world?
Yeah, actually, that's a great question. So the way we see it, actually, right now, I think there's no question with all the great talks that we've heard, like today through now, that AI is definitely here to stay, and is able to achieve accuracy, sometimes comparable, sometimes even better than experts. So I think, but what may be inhibiting the translation is actually trust. So I think that's where the eye tracking comes in, that we have the capacity to not only show a high accuracy result from an AI, but also the regions that the AI uses that are informed by expert eye movements, that are fusion perhaps of expert eye movements and AI attention to really generate something which may even suggest novel biomarkers to experts, just as the experts are informing the AI. So hopefully combined high accuracy plus trustable eye movement informed, domain expert informed AI may help to make the deployment more readily trustable, both for ophthalmic education and for in the ophthalmic clinic for corroboration as a second opinion for experts.
Thank you. Sam, I thought what you presented was also very intriguing, using OCT to identify neurologic disease. I know there are other projects and other companies out there that are using fundus photos as well to identify potentially cognitive impairment and other things that are associated with Alzheimer's. I think it's great that OCT has been formally added to the criteria for diagnosing multiple sclerosis, for example. Do you see neurologists as getting OCT machines in their offices? And how is that going to work into their workflow if they're not familiar with that type of technology?
Yeah, that's a great question. So I'd say, especially since OCT was added to that diagnostic criteria, we've just seen a huge and a lot of excitement, immediate demand from the neurology community for access to OCT data. And they're looking at it in two ways. One is to just have OCT in their own clinics. I think one of the biggest challenges they face in co-managing patients with eye care is that patients don't always go to the eye clinic. That's not where they're receiving their treatment unless they have optic neuritis. So I think one of the most important aspects of meeting that need is developing OCT machines that are actually accessible, so that go past the barriers of cost and size, clinic real estate, and also machines that can be used by patients who have limited mobility or who are disabled, who have paralysis or are wheelchair bound. It's difficult often for them to use conventional machines. But if that's not an option, then being able to get that OCT data from an eye care clinician, but in a way, in a format that is clinically meaningful to them. So whether it's tracking like a traffic light system, yes, there's a significant change in the RNFL over X period of time or since X treatment was started. Something as simple as possible will be helpful.
Wonderful. Andrew, I was really intrigued also by this VLM model that you guys have trained. I think, as you noted, ophthalmologists are actually quite expert at interpreting the OCTs themselves. So where do you see the initial use case would be in medical care for such a model?
Yeah, so in the United Kingdom, where I practice, most of our referrals come from optician practices, optometry practices in the community. And many opticians now have OCT machines, but struggle to interpret the results. So we and many other hospitals in the UK find that 80% of our referrals for urgent treatment of wet macular degeneration, for example, is not wet macular degeneration. So we have a huge problem of patients being referred in for rapid treatment and clogging up the wrong clinics because it's the wrong preliminary diagnosis. So I think this could be really helpful for opticians in the community. Also, specific to the UK system, we have lots of allied healthcare professionals reviewing retinal images in virtual clinics. So we have people of different standards. So it's not just ophthalmologists, it may be nurses who've been trained to look at OCT scans. And again, I think it will help people who have perhaps less experience in the secondary care to manage and make decisions about when to retreat, particularly patients with wet macular degeneration and diabetic retinopathy. So I think I see this as a sort of a co-pilot that would give visual information. It could potentially be used for research purposes as well, trying to identify biomarkers or even novel biomarkers in the future.
Wonderful. Thank you for that. Durga, I thought that using the NLP really augmented the ability to identify these unique patients from the registry that you traditionally were using ICD coding to identify. What other diagnoses do you think NLP algorithms might be applicable for this type of work?
I mean, I actually think there's a broad use for this when we think about, maybe refining cohorts for even common diseases like proliferative diabetic retinopathy, because we're not always coding patients accurately. But I also think that, we're doing a lot of work on this with inherited retinal degenerations because there isn't a specific code for retinitis pigmentosa or choroideremia. And so NLP is really important there, and actually more advanced algorithms, because sometimes the differential is broad and you might list all of those diagnoses in the notes. And so being able to really parse out what is being said about those considerations and what the definitive diagnosis is really important. So I think that's one use case that we're really looking at next.
Wonderful. And our last question is for Stephanie. I think it's really interesting that you're looking at visual performance in a multidimensional fashion. It would be cool if everyone had this on their phone today, right? So how do you think you can, exponentially get people to use this more and help the data flow better for these types of analyses?
Oh, great question. Yeah, we're very much focused at the moment in monitoring of disease. What we're hoping to do in the future is having this run in the background of devices. So if we can map high quality longitudinal, clinically accepted data, but running that in the background when we map that to how somebody interacts with their phone, so how far they are away, how much do they wiggle the phone, for example, so that we can look for changes in even people who are healthy and identify for the first time when people have problems. For me, that would be really exciting, and that's how I see ultimately the use of the technology. But right now, we probably have enough work to do, in the AMD, which is where we're focusing on. And then after that, we're going to be next focusing on diabetic eye disease. But what we now have realized already is that there are nuances even within, neurological, neurocognitive diseases. We're looking now at dementia as well to see how we can pick up vision function changes related to those neurocognitive disease. So that'll probably keep us busy for a while before we get to the point of screening. But
well, that's really exciting. It's almost like how your Apple Watch can tell you if you're having an issue in the background. That's really, really cool. Well, thank you so much to all the speakers here in section 4. We really appreciate you joining us for this meeting, and we'll move on to session 5. So session 5 is presentations that were submitted through our abstract process. So these are all submitted abstracts and reviewed by us and selected for presentation. And so in future meetings, please, use this as an opportunity to submit things as well. Our first speaker is going to be PhD candidate Tania Hagihi, who's going to be speaking about a vision language model to generate high-quality OCT images from text prompts.
Hello, everyone. I'm Tania Hagihi, and I'm happy to be here to share our work and to learn from the innovative research conducted across the field. And today I'm going to talk about our project on developing a vision language model to generate OCT images from text prompts. I'll start by highlighting the current research gap in ophthalmology, then introduce AI models, focusing on foundation models and vision language models, and then the training framework that we developed, and then present the results of our evaluation and conclude with possible directions for future and ethical considerations. Foundation models are large-scale adaptable AI systems trained on extensive datasets that have demonstrated the ability to adapt to different downstream tasks. And vision language models, or VLMs in particular, extend this adaptability by integrating visual and textual modalities together. This alignment between clinical images and corresponding text can enable performing different tasks such as automated report generation or visual question answering and multimodal diagnosis and much more. And research recent works such as Redcliffe and iFound show the potential of these VLMs in enhancing clinical workflows by learning meaningful image text representations. But despite these advancements, a significant barrier still remains. The lack of publicly available data sets that pair OCT images with textual annotations. And this limitation constrains progress on vision language tasks that require rich multimodal supervision. And although previous efforts have explored synthetic OCT generation, they lack text or even label conditioning. Sometimes they generate very poor images in quality, as you can see in top right, or they have multiple models for generating different OCT diseases. And these gaps in current approaches kind of highlight the need for a unified model that is capable of generating OCT images that is conditioned on clinically meaningful text for multiple diseases. Text-to-image generation models have the potential to help with data augmentation, which is especially useful in this domain. And we can generate rare diseases with them while also reducing the dependency on expensive labeled datasets. And while synthetic data cannot yet fully replace real-world data, it provides a scalable and privacy-preserving alternative that can help with VLM development and improve balance in training datasets. In this context, we developed a VLM to generate OCT-B scans directly from clinical text descriptions, and this project aims to explore the feasibility of text-conditioned OCT synthesis as a step towards creating multimodal ophthalmic datasets. And we started by gathering an OCT text pair dataset for training our model, but due to the absence of a paired OCT text dataset, we created our own using the publicly available OCT image only dataset from Kermani. And then we fed these images to GPT-4o and asked it to generate layer-specific textual descriptions, which you can see in the image. And then we used a manual grader to refine them because we cannot fully rely on generated text. And then our final data set consists of 26K OCT image pairs. And for model training, we used our textual prompts describing specific retinal layers and associated features. And we fine-tuned an imaging-based diffusion model by conditioning it on these prompts to generate OCT images. And for evaluation, we used both qualitative assessments by using manual grader and quantitative measures using cosine similarity between image embeddings that we got from a ResNet model that we previously trained on OCT images. And qualitatively, we asked the domain expert to evaluate a subset of 100 generated images. And each image was scored from 0 to 10 based on how well it matched the disease described in the corresponding prompt that we gave the model. And then, as you can see, the model achieved an average score of 8.5 across all the categories, which indicates a strong alignment between the textual input and the visual output that we got from the model. And quantitatively, we evaluated our model by computing cosine similarity scores between the embeddings of real and generated OCT images. And to just give a bit of a context, embeddings are high-dimensional numerical representations of the images, and they can capture essential features like texture, structure, and other patterns that are important for distinguishing the different diseases that are visible in the OCT images. And we extracted these embeddings using a ResNet encoder that was previously trained on OCT data. And to compare the real and generated images, we used cosine similarity that captures how closely aligned the images were, and the closer the cosine similarities to 1 means that it can share, the two images share very similar features. And the model achieved high similarity scores, 0.99 for DME, 0.99 for both normal and drusen, and 0.95 for C and B. And moving forward, our next step includes incorporating feedback from ophthalmologists on the generated images and using more descriptive texts, covering a broader range of retinal pathologies and improving the clinical accuracy and utility of the generated images. In closing, I'd like to thank my advisor, Dr. Minhaj Noor Alam, and our collaborators for their valuable contributions. And thank you all for your time and attention. I welcome any questions that you may have. Thank you.
Thank you so much, Tanya. Next up is Celine Chaya from Mass Eye and Ear, who will be speaking on AI for the detection of maculopathy in pediatric patients with sickle cell disease. Celine.
Thank you for the introduction. Hello, everyone. My name is Celine Chaya. I'm a postdoc research fellow at Mass Eye and Ear, and I work with my mentor, Dr. Nimesh Patel. The title of my presentation today is Artificial Intelligence for the Detection of Maculopathy in Pediatric Patients with Sickle Cell Disease. So what is sickle cell disease? I have no conflict of interest. Sickle cell disease is a hereditary hemoglobinopathy that is characterized by the abnormal production of hemoglobin S, which under hypoxic condition can lead to the blockage of vessels and ischemia. This can happen in the brain and in the eye. In the eye, sickle cell disease can manifest as sickle cell retinopathy, which can be both proliferative and non-proliferative, as well as sickle cell maculopathy. Sickle cell maculopathy is not always apparent on clinical examination, which is why we usually use optical coherence tomography and OCTA, so optical coherence tomography angiography, to detect retinal and macular abnormalities in patients with sickle cell disease. And in the recent years, artificial intelligence has been increasingly used in ophthalmology for automated diagnosis of diabetic retinopathy, but it hasn't been really widely used in sickle cell disease. So the objective of our study was to assess the feasibility of these AI algorithms using OCT images to automate the screening and diagnosis of retinal thinning in children with sickle cell disease. So we included pediatric patients who underwent clinical examination and ophthalmologic evaluation at Boston Children's Hospital from January 1998 to August 2022. But we only selected patients who had good quality OCT done on Heidelberg OCT. And we then did a qualitative analysis of OCT, and we assessed the changes in retinal thinning and in the different retinal layers to assess whether or not there was retinal thinning in these patients. 2 scans from each OCT volume scan were extracted and then analyzed using a 3D slicer using Fiji, and then were assessed using Python. The 2 scans that were used were passing through the fovea and one to the superior temporal area, which are the 2 areas that are most commonly affected in sickle cell disease. We then analyzed the efficacy of 3 different machine learning algorithms. First, there's the logistic regression algorithm, which is a logistic regression of a binary outcome. Then we analyzed the k-nearest neighbor, and finally the random forest. And we compared these 3 machine learning algorithms to see which one can be better used. So the different outcomes that were selected for the study were the classification accuracy, and then we did a cross-validation to test our models, sensitivity, specificity, F1 score, which is a harmonic mean of sensitivity and precision, positive and negative likelihood ratio, as well as the area under the curve. So we had a total of 348 scans of 174 eyes of 87 patients. Half of these patients were male. Most of them were of non-Hispanic origin and of Black race, which is where we find most predominantly sickle cell disease. And the genotype varied between people. We had more than half with a genotype of HBSS. So here we can see our results. We duplicated the data set values to achieve a better estimate. And we can see then the random forest algorithm was the one with the highest accuracy with a value of 100% and a sensitivity, specificity, precision, and F1 score all achieving a perfect value. However, after cross-validating and testing our model, this dropped to 96%. So the random forest model was the one with the better sensitivity and results for our study. And the analysis of individual retinal segment demonstrated superior diagnosis accuracy. This is because the retina is not uniformly affected in all eyes of the patients with sickle cell disease. It is usually asymmetric. And there is a significant possibility of AI in accurately identifying sickle cell maculopathy and or retinopathy using OCT images. Now, our results are very preliminary, but it's important to note that the retinopathy can usually happen in patients before having any systemic outcomes. And this would be important to screen patients and refer them to the hematologist and even other subspecialties to treat. And we can also potentially start treating this patient earlier with potentially laser therapy in the eyes before having any findings of sickle cell retinopathy. Now, there are some limitations to our study. First, it was a single center study, and we had a limited data set that could only achieve using the machine learning algorithms. The next step would be to use deep learning methods. And finally, this was a retrospective study, and some scans were very old, and we had to exclude them from the analysis. So we are planning on expanding our data set and hopefully nurturing this research even more. These are my references, and thank you, everyone.
Thank you for that wonderful talk. Up next is Trevor Lin from USF from South Florida, who's talking about code-free machine learning for the detection of common ophthalmic diseases. Trevor.
Thanks so much for the introduction, Dr. Lang, and thank you all for having me. My name is Trevor Lin. I'm a third-year medical student at the University of South Florida, and today I'll be presenting my project titled Code-Free Machine Learning for the Detection of Common Ophthalmic Diseases. This work focuses on developing AI models for ophthalmic disease classification without requiring any programming expertise, and for this we use Google Vertex AI. So as we might know, vision loss from diabetic retinopathy, age-related macular degeneration, and glaucoma is a significant public health concern. Early detection is critical, but screening methods can be costly and labor-intensive, limiting access, especially in underserved areas. Traditional deep learning models often require extensive coding knowledge, creating a barrier for clinicians without this background. However, recent advances in no-code AutoML platforms like Google Cloud Vertex AI, Amazon SageMaker Autopilot, and Microsoft Azure have made it possible to train models without requiring programming, potentially transforming clinical practice. And as such, the objective of this study was to assess whether physicians without specialized coding experience could use no-code AI tools to develop effective screening models for ocular diseases. So we created two classifiers. One, a binary model to differentiate diseased versus normal eyes, and two, a multi-class model to distinguish among DR, AMD, glaucoma, and normal eyes. Our goal was ultimately to validate the feasibility of these models and provide a scalable solution for primary care, outpatient, and telehealth applications. Okay. Next slide, please. Perfect. So for this study, we used two large publicly available data sets for this study. The development data set, FIVES, included 800 high-quality fundus images equally divided among DR, AMD, glaucoma, and normal eyes, with 80% reserved for training, 10% for validation, and 10% for testing. The external validation data set, EDDFS, contained 400 images with 100 random images for each class, providing a test of our models' generalizability. AutoML enabled model training and hyperparameter tuning to be fully automated, requiring no custom code whatsoever, making this approach fully accessible to non-technical clinicians. And here I thought to provide a sample of images from both data sets, showing the original versus the pre-processed photos on the bottom. And to pre-process the images, we adhered to a no-code workflow using Adobe Photoshop and utilizing the auto function for brightness, contrast, and sharpening aspects in order to normalize and ensure consistency across all samples. So as for the results and the model's internal performance metrics, the binary classifier achieved an area under the precision recall curve, or AUPRC, of 0.967, with a precision and recall of 92.5%. The multi-class model reached an AUPRC of 0.906, with a precision of 87.2 and recall of 85%. These results are comparable to other models seen in current literature, demonstrating that high-performance models are achievable without coding. And so when evaluating the model, when given the external data set, the binary model's accuracy was 92.3%, while the multi-class was 90%. We were also able to gather the model's confidence scores for each prediction, as you can see on the right for the multi-class model. While the model's performance was promising, interestingly enough, as you can see on the top left in the circle, the model showed less certainty for AMD as a whole. And we also observed that AMD false negative confidence scores were slightly higher than AMD correct cases, emphasizing the need for careful clinical oversight. So all in all, in conclusion, our study demonstrates the potential of no-code AutoML to empower clinicians in developing high-performance screening models without programming skills. This democratization of AI could significantly reduce technical and economic barriers, expanding access to ophthalmic screening, particularly in low-resource settings. However, we did find some limitations with the study. For example, we found that the external validation set lacked demographic diversity, potentially limiting generalizability. Also, the use of AutoML inherently limits customization and interpretability, as the algorithm's details are proprietary. Further work is needed to optimize model reliability and assess the clinical impact in diverse populations. And with that said, that will conclude my presentation, and thank you so much for your attention.
Great talk, Trevor. Up next is Apurva Safai from University of Wisconsin, who will be speaking about the early prediction of GA using autofluorescence imaging-based AI models.
Thank you, Dr. Lang, for this opportunity. So my presentation here is today on the early prediction of geographic atrophy using autofluorescence imaging-based AI models. So as we know that geographic atrophy is an advanced form of age-related macular degeneration, which affects more than 5 million individuals globally and is rising steadily with the growing aging population. And the prediction and localization of GA is crucial as factors such as lesion size, location, and directionality of lesion enlargement can determine the degree of visual dysfunction. And hence the clinical motivation here in identification of patients at risk of progressing from intermediate AMD to GA is to effectively screen the patients who stand to benefit from different clinical trials such as the ERIDS trial that are looking at supplements that can be useful in treating GA and treatment and management of GA. And moreover, predicting the risk of progression to GA would also allow an early initiation of these currently available therapeutic methods for greater preservation of the retinal tissue. And we know that there are certain risk factors that are associated with GA, and mostly the lifestyle factors such as smoking, age, heart diseases, high blood pressure, fatty diet, obesity, and genetics. So, and apart from this, studies have shown that FAF imaging has also shown some signatures that can be predictive of progression of GA. For instance, one of the paper from a group has previously shown that in the initial stages of development of GA, the FAF images show more of a hypoautofluorescence pattern, and that gradually changes to a hyper-autofluorescence pattern as the GA grows. So considering these factors, we hypothesized here that an AI-driven model that uses FAF imaging could improve the predictive capability of predicting the 1-year occurrence of GA. And we also explored the utility of multimodal AI models that combine both the imaging as well as the clinical and lifestyle factors in the prediction of this 1-year occurrence of GA. So the data set here for the study consisted of the ERIDS-2 trial, and here we had 2 groups, wherein one was the cases where the subjects from their baseline visits, the subject developed GA 1 year later, and the controls were subjects that did not develop GA 1 year after the visit. And the total sample size consisted of 203 patients altogether, 203 subjects altogether, wherein 71 subjects developed GA after 1 year and 132 subjects did not develop GA. And the models that we evaluated in this study were of 3 types. One was the image model, which used only the FAF imaging for prediction. The other was the clinical model, which used only the clinical data, clinical and demographic data for prediction of occurrence of GA. And the final one was the multimodal model, which combined both the imaging and clinical data for predicting GA. So in the image model, the input was the FAF images, the baseline FAF images that were given to an efficient net architecture. And in the clinical model, the clinical data features, the 10 clinical data features were given to a 2-layer multimodal, 2-layer neural network architecture. And the embeddings from both of these models were given independently to a predictive framework, wherein these embeddings were fed to a fully connected layer that could generate predictions of whether the subject would develop GA or not. And this framework also consisted of an interpretability setup where we could visualize the GradCam maps generated from the imaging model. And then the multimodal framework basically used the embeddings from both the imaging as well as the clinical data, and both of them were then combined using a transformer block, which could effectively assess the interactive patterns and dependencies between the 2 embeddings, and this was then given to the predictive framework to predict the 1-year occurrence of GA. And so what we saw here was that among the 3 models, the image model showed the best predictive performance in predicting GA with an accuracy of 95% and a high and balanced sensitivity and specificity performance, followed by the multimodal framework, which gave an accuracy of 89 and balanced sensitivity and specificity performance. The clinical model showed a relatively lower sensitivity of 73 compared to all the 3 models. And through the interpretability framework, we could see where exactly the imaging model that showed the best performance actually looked at the images while generating the predictions. And these are the two set of images of 2 cases, wherein the first row shows the first row shows the baseline image, which was given as input to the model, followed by an image of the same subject 1 year after, which did develop GA. And we can see that in both the subjects, the AI model was able to highlight the foveal activation area where the GA did develop 1 year later. We can see that the AI model did focus around the hypo-autofluorescence patterns. Whereas in the control subjects, we could see that the AI showed a more diffused activation patterns in the GradCam maps. So to conclude, we can say that the AI model that is trained on FAF imaging did demonstrate a high predictive capability in predicting the 1 year onset of GA in intermediate AMD patients as compared to the clinical factors alone that are seen in the clinical setup. And although the FAF imaging model does seem promising, the multimodal model may need additional investigation in order to identify the best combination of clinical features and imaging modalities to give out a better prediction of, to give out a better early prediction of GA. That's all. I would like to thank these grant bodies which have facilitated the work, and also the Wisconsin Reading Center at University of Wisconsin-Madison. Thank you. Thank you everyone for your time.
Thank you for a wonderful talk. Next up is Niccolò Bartolomeo from Lausanne, Switzerland, who'll be speaking about AI-driven OCT biomarker quantification in neovascular AMD patients treated with aflibercept 8 milligram.
Well, thank you, Dr. Lang, for introducing the title of my presentation. I'm Dr. Bartolomeo, and I thank for the opportunity to share the results we have in Swiss Visio Montchoisy. So I have no financial disclosures for this talk. And can we go to the next slide as well, please? Okay. So as we saw today in all these sessions, ophthalmology as an imaging-based medical field will definitely be enriched by all these technological advances. And with my talk, I want to show you how we used AI to quantify OCT biomarkers to evaluate the treatment efficacy of aflibercept 8 milligram in our cohort of naive NAMD patients. So our cohort consisted of 32 eyes. The baseline visual acuity was of 68 letters. Mean age was 8 years old, and there was a female predominance. Due to the higher molecular dosage of aflibercept 8 milligrams, we used an adapted observational protocol with 3 monthly injections for the loading phase, and this was followed by a monthly observational phase until fluid recurrence, which was then used as a tailored treat and expand regimen with an adjustment of 2 weeks. I have problems with going forward with the slides. So currently, without AI, we can quantify and evaluate outcomes of treatment by functional outcomes. And here we can see that visual acuity gradually increased over time until reaching significance at month 3 and at month 6. And also we have manual CST and PED height measurements that significantly dropped after 1 injection and remained stable during the whole observational period. Another qualitative analysis was to assess, without AI, the time to first fluid absence. And we can see that in all our cohort, after 1 injection, more than half of the population was completely dry, both in the intraretinal and subretinal compartment. But back to our visual acuity graph, the question is, how can AI provide a better explanation of why there is an increase of visual acuity? So we integrated Retina AI with this advanced segmentation, and we quantified all of the biomarkers that you can see on the screen. And we noted that after 3 monthly injections, all of the parameters that were quantified were significantly decreased. Here is a case example of how rich in details AI can be, and compared to the previous binary assessment of is there fluid or not. And all these details that we can extract are translated to a very efficient and detailed evaluation of molecules that are used for NAMD. Here is another graph where we see the dynamics of all fluids in all our cohort during the whole observational period. But now back to the question. So how can AI can improve the explanation of our functional results? Well, by quantifying all this data, we can see on the top right the dynamics. So there is a significant decrease after one injection, and thanks to the higher dosage of aflibercept, there is a tight disease control, and this translates to a gradual and steady increase of visual acuity. And this is in line with a study published by Professor Schmidt-Erfurt and the team where they show the correlation between volumes and visual acuity. Also, by quantifying these biomarkers at baseline, we were able to use them as predictors. Indeed, we noted that higher intraretinal fluid volume and higher hyperreflective foci quantity at baseline were predictors of visual acuity after loading and at month 6. Regarding durability, 70% of our population reached an interval of 8 weeks at month 6 with a relatively low number of injections. So to conclude, aflibercept 8 milligrams demonstrated a rapid and significant drying after one injection. It demonstrated a long durability with few injections and no safety signals in the short term. Moreover, by leveraging AI to quantify OCT biomarkers, we can really have an enriched assessments of the outcomes of aflibercept 8 milligram injections, and also we could establish short and intermediate functional outcomes. Thank you for your attention.
Thanks for that great talk. Up next is Spence Cox, who will be speaking about a fused convolutional neural network to identify mild cognitive impairment using multimodal retinal images. It's from Duke.
Hi, I'm Spence Cox, a junior undergraduate with the Duke Eye Multimodal Imaging and Neurodegenerative Disease Research Group, or iMind. And today I'll be talking about our results from testing a fused convolutional neural network to detect mild cognitive impairment and the challenges we have met. Switch slide, please. So MCI is a state of neurodegeneration that often appears as a precursor to Alzheimer's disease, and its effects are visible in retinal images. Antemortem testing, usually through MRI screenings and cerebrospinal fluid sampling, is expensive and time-consuming. And an alternative non-invasive testing can quicken treatment of both MCI and Alzheimer's. A previous multimodal CNN from iMind achieved an AUC of 0.809 in classifying MCI from retinal images, demographic information, and quantitative image data. Switch slide, please. One type of imaging we use is optical coherence tomography angiography, a non-invasive method to visualize retinal microvasculature that produces high-resolution maps and detects subtle abnormalities. We also used ganglion cell interplexiform layer imaging, which is an OCT-derived map focusing on ganglion cells and their synapses. Additionally, we use HD21 line imaging, a high-definition OCT scan, and RNFL maps, which measure the thickness of ganglion cell axons around the optic nerve. Our previous model used quantitative data, demographic information, and retinal images, and operated under a smaller image dataset. We found that quantitative data strongly guided decision-making in the model. Our current data set is composed of 6,030 images from 468 control subjects and 203 MCI subjects. And we applied an 80-10-10 split between training, testing, and validation sets. The MCI patients were diagnosed based on clinical history, cognitive testing, and neuroimaging when available. With this project, we aim to improve on our previous model by using a fused CNN structure, trained only on retinal images. Our previous model made diagnoses for each image type, which were then averaged together for a final prediction. In the fused model, images are sent through their corresponding image type submodel, where image features are extracted. These submodels are trained on the EfficientNet V6 pre-trained algorithm. All of the image features across image types are then concatenated and sent through a final classification head, which outputs a prediction. This method can offer more robust conclusions, as the model uses all relevant patient data together rather than separately to make a diagnosis. Unfortunately, after training our model, we found that our fused structure performed weakly compared to our previous model that used demographic information and quantitative image data alongside the retinal images. The diagnostic accuracy at around 64% did not show a strong understanding of the data set. The specificity of the model was higher than its sensitivity, probably due to there being more control patients within the data set. We conclude that the model was damaged by the omission of the demographic information and quantitative image data, and that it cannot identify MCI from retinal images alone at this point. And we hope to overcome this by procuring a larger image data set and also adding in ultra-wide field color images to supplement decision making. We also plan to test the model using only images from amnestic MCI patients who progress to Alzheimer's at a higher rate. Thank you for hearing about this project from iMind.
Thank you for that really interesting talk. Our last speaker is also from Duke. It's from Jay Swaminathan, who will be speaking about interactive scholar search using large language models as conversational agents for journal articles. Jay.
Thank you, Dr. Lang, for that introduction. I'm a third-year medical student at Duke, and today I'll be talking about some of our work surrounding using large language models to query journal content. The volume of literature in ophthalmology and medicine in general has grown exponentially over the last 2 decades. And as of this month, there are over 145 ophthalmology-focused journals in existence. And between 2017 and 2021, there were over 10,000 ophthalmology-related articles published, which is an average of around 5 per day. Searching for information in this environment is becoming increasingly challenging, and we believe that large language models have a role to play in simplifying and augmenting the search process. We created a large language model-based conversational agent for the Duke Journal of Case Reports in Ophthalmology. It's an open source journal with publicly available content. Next slide, please. Thank you. In terms of advantages, many LLM tools exist for summarizing medical information. Many of you have probably used Open Evidence, and Google is also developing their own healthcare-focused large language models. In terms of creating a domain-specific LLM application, it allows you to leverage these state-of-the-art technologies, but also adapt them to your own needs. So you can customize sources of information, whether they're peer-reviewed journal articles, surgical textbooks, or administrative protocols, and update these resources over time. One of the main drawbacks of large language models is their tendency to hallucinate or fabricate false information when asked to provide an answer. And by anchoring responses in a body of literature that you've provided and asking for citations and quotes from the text, you can reduce their tendency to hallucinate. You can also have conversational interactions with these systems. So think of the difference between asking a single shot query to Google versus having a conversation with ChatGPT. There are many versions of these models that can be run locally on your machine, and no data is transferred to corporations for training purposes, so they can be HIPAA compliant as well. And you can fully customize the output to suit your unique needs. Next slide, please. In terms of our methods, our chat system was developed using a retrieval augmented generation framework on OpenAI's GPT 4.1 large language model. We started by generating numeric embeddings for the article text and storing these embeddings in a database. Our user query is entered through our front end, and the user query is also embedded. The most similar article information to that user query is extracted from the database using semantic search, and the user query, most similar article content, and the prompt are fed to the LLM to generate a custom response. In terms of validation process, our initial evaluation was done by drafting ground truth questions from DJCRO content. We compared ideal human-generated answers to LLM-generated answers by cosine similarity, which compares word order and word content. And further evaluation with more complex queries and semantic similarity metrics are in progress. This is just an example of our LLM response, ideal human response, and the text from the original paper. I highlight this because you can see that the LLM response and the ideal human-generated response share a similar structure that reflects the original structure of the paper. First, they describe traditional treatments for thyroid eye disease. Next, they go into newer biologic options. And third, they identify patient populations where these options might be particularly useful. In terms of our results, our retrieval augmented generation answers showed close alignment with the ideal human-generated answers with an average cosine similarity of 0.81. And simple queries showed greater alignment. So as you can see, question 2, for example, has a cosine similarity value of 1 between the LLM answer and the human-generated answer, indicating that they were identical. And this question asks for the expansion of an acronym. So naturally, we would expect that the human-generated answer would be exactly the same as the LLM response. In terms of conclusions, we believe this effort demonstrates the potential for creating custom conversational information retrieval systems in ophthalmology. Think of an AI index that not only allows you to identify articles on a specific topic, but also generate summaries and ask questions. These tools are highly scalable, easy to build, and easy to update over time, especially when you have a basic framework in place. And our future evaluation will focus on rigorous evaluation of response accuracy with more complex queries, assessing semantic similarity of the ideal and LLM responses, so making sure the information content is the same, decreasing the time taken to generate responses, improving how concise the responses are, and incorporating other journals and evaluating findings from different journals. These are my references. Thank you very much for your time and attention.
Great. Well, thank you so much for everyone's participation in this OAI Summit. This is our 5th year. As we sign off here, I definitely want to thank our sponsors, Regeneron, Apellis, and Genentech, for your sponsorship of this meeting and bringing this to light. And we'll see you all next year.